So welcome everybody for this webinar of the World Federation of Neurorehabilitation on World Brain Day. World Brain Day is an initiative done by the World Federation of Neurology, and the idea is to alert the world public on the importance of brain health in terms of prevention, in terms of rehabilitation, in terms of leading a good and healthy lifestyle, and so forth. The brain is probably the best we have. It's certainly our most important organ, which in some sense determines ourselves in any respect. And therefore, it's important year by year to alert people to think a little bit about what we can do even to improve brain health. So I may give the word to Professor Wolfgang Grisel, the
Hi.
president of the World Federation of Neurology, to say some words about the WFN background of this.
Thank you, Volker. Thank you, dear colleagues. It's a pleasure to be here. I'm presently in Beijing, in China, and I was invited by the Chinese Society to speak at their Brain Health and Prevention Initiative this year that was taken up to the highest political levels. And there was the Deputy Minister of Health speaking, and I think it's a good model on how societies can implement the World Brain Day. There was also something I never knew of, that was a free access for outpatient consultation in the hospital on the occasion of the Brain Day. And this was done by volunteers who did this on their own just to promote the World Brain Day. So as Volker said, it's a very important initiative, and we have done this now for the 11th time. We have several topics, but I think the last series of 3 World Brain Days was always devoted to brain health. And I think brain health as the overarching envelope is very important. In particular now to this upcoming IGAP and the IGAP toolkit that we have learned of in the past weeks, and you will hear later on, this is important, that it gives us also an important tool how to promote and how to move along. 2 thoughts. I hope you have seen the webinar before, and it reached the target because it showed clearly that if we speak about prevention, the regions of the world have completely different needs and ideas. Overarching is stroke, that's wonderful, maybe epilepsy, but if you look at infections, if you look at non-communicable diseases, this is something different, and I'm very glad that our regions were able to put this into the right perspective. I'm also very grateful that the WFNR collaborates so well with the World Federation of Neurology, and I would say it's a continuum from diagnosis to treatment to prevention to rehabilitation. And I was also to see a huge rehabilitation center today in the Chinese hospitals with robots and all kinds of things. I think you would be really envious how many things they had here. So I think the idea of rehabilitation is catching on, and it's not something that's something you do, but it's something that needs to be done. And with that, I thank you very much for our invitation. And I do look forward to much further cooperation. And I think with Volker and myself in the German-Austrian position of being presidents, there's an optimal connection of needs and of thoughts. And we appreciate our very direct contacts that we have very often. And this is to the fruitful, I think, for both societies. With that, I thank you and hand over back to Volker. Thank you.
Okay, thank you very much, Wolfgang, and it's more than a pleasure for us to join the WFN initiative. And to be honest, he is in Austria, I'm in Germany, but we are not Eurocentric. I think we are certainly on an absolutely international level, as you will see today. And we have prepared a program, and you will probably learn a lot from various aspects. Look at rehabilitation on this initiative of brain health. I may ask Professor Daphne Morigiano, who is the president of the European Federation of Neurorehabilitation, who jointly with us is organizing this. Daphne, do you want to say some words?
Yes, definitely. And I'm extremely honored and happy to see this cluster of top-notch societies working together for this important day. And I think this is our great pleasure to have here Wolfgang with us. Even if he's far, he's always present with us and always working in a very, I would say, very integrated way, and we are happy to be there. I would like to highlight, first of all, the idea that WFNR, it's so active in the last years around the world, actively changing and reshaping the landscape of neurorehabilitation. And we, as a European Federation of Neurorehabilitation, we are doing, I would say, simultaneously this work here in Europe and beyond, because we are trying to extend our efforts also in Central Asia. As we know, we recently had important meetings there, and we try to put, I would say, to infuse more competence and to infuse the spirit of neuro rehab of WFNR. And just want to highlight this important joint and I would say mirror cooperation between EFNR and WFNR. EFNR, it's a subunit, and we are considering part of the big family, and whatever we are doing together. Of course, having World Federation of Neurology always with us is a great honor. Pushing together towards education, as we have done, we have created a lot of cooperation also with European Stroke Organization in the last years, and beyond with the World Stroke Organization, we are doing important, I would say, educational programs, working for science and serving people by creating and working together for guidelines. And I think we are living a new era for neurorehabilitation, and you will see along the way surprisingly changes in our landscape. And I think, and I would like to thank Volker for integrating all this. And look here today, we are doing together with this great team, with all our colleagues from and the board of WFNR and all the others, trying to match our efforts into the melting pot of neurology all over the world. Thank you very much, Volker, and let's get a good program today. And again, very proud for doing this together.
Okay, thank you very much, Duffy. It's all a pleasure. You know, we are working together more than 20 years, especially centered around education and bringing forward services in Europe. And before I start a short presentation of WFNR and its position and future elements of what we are doing, let me express my gratitude to all the people who helped us to bring this about today, from the Presidium of WFNR, from especially Tracy, as my executive director for WFNR, and especially also to Duffin's team in Romania, who help us again with very high efficiency to broadcast this in a worldwide way. Okay, so let me start giving some short introduction from the WFNR side, what we are, what we stand for, and what our ideas about the thematic elements for World Brain Day are. Christian, you can start this video now.
So, hello everybody, irrespective where you are in the world, welcome to this webinar celebrating World Brain Day. You know, World Brain Day is an initiative by the World Federation of Neurology, and the World Federation of Neurorehabilitation is proudly supporting this. This year, the motto of World Brain Day is Brain Health and Prevention. Allow me to say some words on WFNR and what direction we are going to work on brain health and prevention. We had similar experience last year, which was very successful on World Brain Day, with the motto Leave No One Behind, looking at prevention, awareness, access, education, and advocacy problems. And for this year, I think we are going into the same direction. WFNR has a mission with 3 pillars. One pillar is to advance research, second pillar is to advance education, and third pillar is to advance clinical practice in neurorehabilitation around the world. We are a multidisciplinary interprofessional society which is open to any professional with an interest in neurorehabilitation. That may be PMR specialists, neurologists, neurorehabilitators, neurosurgeons, PTs, OTs, neuropsychologists, logopedics, child neurologists, neurorehabilitators of any form, neuroepidemiologists, engineers, including also more and more philosophers and jurists in the field. We are organized in the way that we have 43 national societies. The number is increasing year by year across the world with over 5,000 individual members. In the way that all members of national societies are also automatically members of the World Federation. And in this sense, we are probably representing more than 55,000 professionals in this field around the world. Okay, we have a world-spanning distribution. We have only very small blind spots or white spots on the world landscape, but we have a more or less almost complete international representation. So when we look at the global situation, you will be familiar with this data from the World Health Organization published in late autumn 21, stating that over 1 billion people live with some form of disability, with an increasing number of people in this respect, not at least due to demographic trends and increasing chronic health condition, among other causes, especially degenerative diseases, and also, of course, hypertension, diabetes, and so forth. People with disability are disproportionately affected during the COVID-19 pandemic, and we still see late sequelae of this almost everywhere in the world. That is gradually decreasing, but nevertheless it's still a problem. When you look at the crude figures, then WHO says that we're faced with a situation that 1 in 3 people today are estimated to be living with a health condition that benefits from rehabilitation. And rehabilitation is an essential part of the universal health coverage, along with good health, prevention of disease, treatment, and palliative care, and so forth. Globally,
What's happening here?
2.4 billion people are currently living with a health condition that benefits from rehabilitation. That are quite significant, big numbers. So we are dealing with a huge project. We are dealing with a huge task we are faced with. When you look at the resources in contrast, then we will see that almost all resources around the world are not sufficient to fulfill this. So there is a remaining gap. This gap is more marked in low middle income countries compared to richer countries in the world. If you just look at the number of people for every single, let's say, physician, then you see in Africa we have 3,600 or so, which is better, of course, in Europe and richer countries around the world. But nevertheless, even these numbers will not be sufficient in future, in near future. And with near future, I mean the next 20 to 30 years, to enable a coverage of decent rehabilitation in the world. So we are faced with a situation that hundreds and hundreds of millions of people in the world will not, in near or nearer future, have access to what we believe is decent neurorehabilitation. So we have to change our mind in the sense how we bring this knowledge, skills, information about neurorehabilitation to the people everywhere. So WFNR emphasizes to all our countries that we want to take a lead on brain health promotion and also prevention of neurological disorders across the lifespan. And we do that through special interest groups which have devoted tasks, let's say stroke or traumatic brain injury, or particular techniques as neuromodulation or brain-computer interfaces, technology aspects, and so forth. So the idea at the end of the day is to ensure good living conditions in terms of food, water, housing, education, and healthcare. Decrease risk factors for the most burdensome conditions affecting the brain, which is especially stroke, TBI, it's also spinal cord injury, and of course also dementia. Increase decarbonization of energy supplies around the world to decrease the risk of climate changes. Ensure safe ways of mobility, protection, helmets, protection systems, and so forth, protection systems in all sense, to avoid the sequelae of traffic-induced traumatic brain injury. And which I think is really very, very important today. Unfortunately, we are still faced with a situation that unnecessary hostility and wars will increase the number of people with traumatic brain injuries tremendously. When you look at the figures, you will see that in a couple of minutes I come to that. We are trying to help the WHO with their Sexual Global Action Plan, IGAP, implementation at global level. One way of doing that is to roll out community-based education programs for rehab of neurological disorders. We have currently about 9 or 10 of these projects running in various parts of the world, and the idea is to help people in the community, caregivers, families, to deal with aspects of neurological rehabilitation. And one way of doing that, you'll see that in a minute, is the complete representation and implementation of a new rehabilitation setting in a digital world. You could call it the metaverse, if you like, for education of patients, caregivers, families, and so forth in an interactive way. We are just running a global survey on resources and future needs, and neurorehabilitation is still going on. I hope by the end of the year that we will have a clear delineation of the data structure. We issue free of charge ebooks. We have done a very successful one on stroke rehabilitation. We are just planning a next one on pediatric and another one on cognitive rehabilitation strategies. We are designing a toolbox for health economic support, which can address the individual needs of countries at different economical level, especially low-middle income countries, of course, what health economic principles have to be followed. And you will see that in the course of this webinar today, also definition of minimum requirements, especially for stroke and TBI. We're looking at wars. This is the number of deaths in armed conflict based on different areas in the world. You see there is quite a lot. It's higher in some areas, it's fortunately lower in other areas, but it's a major source of concern. And when you look at combatant death in conventional wars, interstate wars and civil wars, going back to 1800 to today, the impression appears that mankind has not learned very much. We are still involved in various areas of the world in some sort of combats, giving rise to a lot of human suffering and to a lot of needs for rehabilitation. WFNR is a non-political organization, so we never support one or the other side of an armed conflict. We are completely neutral in this respect, but our general thinking, however, is that we conceive all wars as being pretty irrational, maybe aimed towards increase of territories, wealth, or just thematic aspects and power and glory. And we conceive it as being a violation of the human mind, because the human mind should be able to solve conflicts without killing people and without generating a tremendous amount of suffering and a need for rehabilitation. Nevertheless, we see this need and we see the necessity to support all victims, and we have strategies in that. I mentioned that already, that digital communication tools may give us a chance for low threshold spread of rehabilitation knowledge and procedures. If we have learned anything good from the COVID-19 pandemic, then it was certainly that we have increased our ease in dealing with digital communication tools for communication. And we think that this is a good way to close the gap between needs and available resources, in the sense that using such technology, we can roll out knowledge, procedures, strategies for neurologic rehabilitation. I will show you a video of this in some seconds. The idea is that you are entering a metaverse representation of a rehabilitation setting. You can meet people there, doctors, therapists, and so forth, and you can interact with them. This is driven by an artificial intelligence system, and we can freely program this so that we have control about the information which is transferred to people. So a patient, a therapist, a caregiver, whoever can go into that and ask questions and get answers and can see how particular, let's say, therapeutic interventions can look like and so forth. So I go on and
I am Dr. Mark Harrison, a neurologist at the Dubai Center of the World Federation for Neurorehabilitation, WFNR. I diagnose, treat, and offer rehabilitative care to patients with neurological disorders. Yes, I can recommend exercises after a stroke. It is important to consult with a healthcare professional to determine the best exercises for your individual needs. One example of an exercise after a stroke is seated leg lifts. Sit in a chair with your feet flat on the floor. Lift one leg straight out in front of you, hold for a few seconds, and then lower it back down. Repeat with the other leg. This exercise helps improve leg strength and coordination. You're welcome. If you have any more questions, feel free to ask.
Okay, that was basically all I want to say for today. Gives you just a glimpse of what activities we are working at the moment. Next Congress for World Federation of Neurorehabilitation will be 2 years' time in South Korea. We just had one months ago in Vancouver in Canada. I hope that during the course of this webinar you will get some more detailed ideas about what WFNR is doing in the field of neurorehabilitation in close conjunction with the World Federation of Neurology, in close conjunction with the European Federation of Neurorehabilitation, and all the other bodies involved in the world working in this direction. Thank you very much indeed.
Okay, so we are back. This was just an outline, and in the course of this webinar, you will certainly see much more. Let me alert the audience to use the chat room and the question answer boxes. It's certainly, we would like very much to have this interactive in the sense also answering questions in between. And I think it's probably also for the audience much more fun if you be interactively with us. At the moment, let me have a look at it. Look at the chat room, which is unfortunately empty for the time being, but we can proceed to our next speaker. I think it's Matilda Leonardi. She is there. Matilda
Hello, everybody. Yes.
is a neurologist and a neuropediatrician from Italy, and has a long, long history in working with international bodies, especially also World Health Organization. And for the World Federation of Neurorehab, Matilda is our most important key person in interacting with WHO. And she's going to talk a little bit about the Intersectoral Global Action Plan, which we mentioned already, and the WHO inputs for global health. Matilda, go ahead.
Thank you very much. And good World Brain Day to everybody, to all those that are listening to us. And I really am happy to speak also in front of the president of the World Federation of Neurology. I think together this big world organization are pushing, and I think we have a role for the next year, which has been assigned also from what I'm going to say in the next minutes by the World Health Organization. It has been already said that the WFNR is advancing research, education, and clinical practice in neurorehabilitation. But we're doing this in a line that is in the era of the neurology, so-called neurology revolution. That is the era that started, we could say, after the end of the pandemic 2 years ago in 2022. But taking the experience of what happened during COVID, I think is something that we are bringing with us in our revolution. What happened is that how health crisis was not only a crisis of biomedical and biomedicine, but it was involving political, social, cultural, and economic dimensions. I think we have been learning this, and we have to work within the neurology revolution, having this clear in mind. We're not only dealing with something that concerns health, but the future health governance is more efficient if it is thinking in a syndemic manner, in a biopsychosocial manner. And to do this, I think we are now moving on some solid data. The publication last March of the Lancet issue, which was producing the GBD, the Global Burden of Disease data 2021, was giving us some data that are a fact, that are a big change from what happened in the first GBD, GBD 2000, which was based, and we can say that these 24 years have been marking a real big change in the world of neurology in terms, at least, of awareness and knowledge. If you're not counted, you don't count. That was clear. But in 2000, we had data on very few countries, and the data were very poor from great parts of the world that today are contributing to the burden of disease. And we had sort of a missing in Southeast Asia, Africa, all Eastern Mediterranean and Eastern Europe. So evidence was lacking everywhere. In 20 years, we've been increasing evidence, and the last data from the 21 regions of the global burden of disease, which is also done in collaboration with the World Health Organization and the Institute for Health Metrics, as well as with the Bill and Melinda Gates Foundation, it is telling us that there is a new era, an era in which neurological conditions are the leading cause of ill health and disability, affecting 3.4 billion people worldwide. This was the big news after the publication of the Lancet paper, meaning that at least 43% of population is suffering from one neurological disease. Not all of them are needing rehabilitation. But as Professor Volker has been saying, many of them could benefit of rehabilitation, which is not considered at the same level of answer as it should be the number that is the epidemiology and the burden is giving to us. Meaning that the disability worldwide provided by the neurological diseases is very big, and it is increased by the lack of personnel. That is a data that at least for Europe is one for around 100,000, but as you have seen in some other regions of the world is even less, and the increase in direct and indirect cost. The GBD study 2021 is really interesting because it's adding new diseases and is also telling us information about a decrease in mortality and an increase in disability, saying that we have been able to reduce the mortality, probably because of the improvement in stroke care, but we have not been able to reduce the disability. On the contrary, disability increased in the 2021, telling us that this information about disability is even bigger in the low and middle income countries. I think that most of these change also in the burden is related to the fact that new diseases have been introduced, particularly diseases regarding the youngest age of the population, which in the low and middle income countries are considered the big majority of population. The introduction of neonatal encephalopathy, preterm birth, and autism is increasing in the 10 first causes of disability due to neurological diseases worldwide. And it is interesting that in these 10 diseases, 3 new diseases are ranked there as big causes of disability. There's not big difference between the different regions of the world, but there are some differences also telling us that neurology has to be seen. Some diseases are more or less the same rank in all the parts of the world: stroke, neonatal encephalopathy, migraine, and dementia. Despite some variability, they're not that different. However, meningitis, tetanus, multiple sclerosis, and motor neuron diseases vary a lot in terms of their ranking according to the different regions. So when we speak about neurology, we also have to consider that not all diseases present in the same manner, in the same regions, and not all the rankings are the same in the different regions of the world, meaning that also the intervention could have a tailored approach and cannot just go with one manner. Also, it is important to say that we never really spoke that much about the differences in neurological representation of different diseases in males and females. Females, as we know, are more affected by COVID and long COVID, by multiple sclerosis, migraine, dementia, and tension type headaches, which means that there is also a gender type disability that we have to consider according to the different types of population that we are considering. So there are females that in many countries have less access to care for whatever reasons that we are not going into now, but they're also then suffering a double burden. Being a female with a neurological diseases, which is very much frequent, is also something that when we think about brain health, we should also put in our debate as one of the things that we should consider when planning what is good to do to reduce the burden of diseases. Well, in this Lancet, as we mentioned, these new causes of disability regard mostly the children, but it is important to say that we are expecting even a greater burden in the next burden of disease, because we have not been including in this burden of diseases such as the post-COVID fatigue, the vestibular disease, the neuropathic pain disease, and on purpose, I leave as last sleep diseases. We are expecting that if and when we are able to calculate sleep disorders, the brain of neurological condition is going to be even more. Are we ready for this burden? What are the instruments that we have for these numbers? As long as we are all aware that there is not an equivalent action and political action in none of the countries of the world for this big burden that we are now, thanks to the global burden of disease, facing. Because the burden of disease is not only the epidemiology, it is also sufferance, stigma, cost. It is also a problem in terms of health professional. It is also a problem in terms of the content of training. And I think these days that are interprofessional days are important, because what is missing is interprofessional training. We need neurologists able to read neurophysiological data as well as neuroradiological data, but also to be aware about cardiology as well as the internal medicine. And the more the science is going on, we need the neurologist able to interlink between neurology and psychiatry. We need rehabilitation able to think to the people, not only as the body that they have, but the body, the brain, and the mind that they have. Because also many of the countries that are in the world do not have specific brain health plan. And most of the activities to deal with neurology and neurological patients are fragmented or just focus on some diseases or on some age sectors. The unnecessary and impossible separation between neurological and psychiatric disease is something that we might wish to discuss in the next month. I think that the next month we'll also have to see how can we strengthen efforts and forces. The more research is bringing us towards a combination of neurology and psychiatry together. The other element that can help us to face the burden is also that in 2022, as we all know, the WHO released the Intersectoral Global Action Plan. In a sense, the plan was seen as the instrument to raise awareness, global awareness, even within WHO, that is also a fragmented organization, as much as all the countries are fragmented, to give attention to all neurological diseases, starting from epilepsy and going into many other diseases. And it was calling for big collaboration of the health sector, but also the welfare sector, the social, the education, and the labor sector. The goals, most of the goals are related to something that is not only for people who have neurological disorders, because most of the goals are to improving brain health, which is a value for all countries and all citizens, but also to see that reducing stigma and burden and improving quality of life is one of the mandatory goals that is divided in 5 strategic objectives from 2022 to 2031. So we still have some years, 7 years to reach the goals that are put there. And the goals are 5 goals with different targets. And I think that most of the countries now have been reaching already in 2024 the target 1 of goal 1, which is 75% of countries have some national policies. We are not there. But I think that goal 1.2, also with the events like today, is very close to be reached well before 2031, which is that countries have at least one awareness campaign or advocacy program for neurological disorders. I think the efforts we all have to do is to implement the awareness about brain health in all the countries, and events like the World Brain Day today are exactly in achieving this target in goal 1. But the WFNR, as it has been shown, is as neurorehabilitation suffering another part, which is that neurorehabilitation, despite the Rehabilitation 2030 WHO initiative, is still not a health intervention for many countries. So it's not embedded into the health financing that is going to be provided within the objective of the Sustainable Development Goal of universal health coverage to all citizens. So we try to give an integrated response to neurological disorders in which rehabilitation is one of the pillars and is one of the elements that should be considered as a key element that can prevent the worsening of the situation and sometimes can also make a big improvement so that people can go back to a better quality of life. But to understand brain health around the world, we need more, because we think that just knowing the data and just having the Intersectoral Global Action Plan could not be enough. We have other elements. We have the Sustainable Development Goal, UN policies for aging, UN policy for non-communicable diseases. But when we say understanding brain health, it means that we are all protagonists and actors of a campaign in which we take into action what it is written in the WHO, Optimizing Brain Health Across Life course, which is a technical complement of the action plan, which is trying to explain what it is important for brain health and brain health optimization, and which are the determinants of brain health. On this, many organizations like WFNR or European Academy of Neurology, as well as other regional big neurological and the patients organization like the WFNR or the International League Against Epilepsy or World Dementia, they've been trying to embed this definition of brain health, which was provided by WHO, within their own policy. It's not easy, but it is what WHO defines as brain health, a state in which every individual can realize abilities and optimize cognitive, emotional, psychological, and behavioral functioning to cope with life situation. In fact, this definition looks a bit difficult to be operationalized, and it is related to the fact that once you start speaking about brain health, there will be no health without brain health. So brain health at the end refers to the overall well-being and optimal functioning of the brain, as well as know how can you maintain your cognitive functioning, emotional, as well as ability to think, learn, and remember. So healthy lifestyles comes in very strongly, and to maintain or adopt healthy lifestyle or engaging in activity that stimulates brain is a change in mindset also for us doctors, for us neurorehabilitators and neurologists of the world, because we need to enter very much in reducing the burden, thinking to the brain health in a broad activity, which is, as I said before, syndemic, which involves many sectors. We still are very much in an era in which research is very important. But this is the image of the European Academy of Neurology. We want to plan activities, and to plan we have social policy, but also environment. We need to protect and prevent, and many has been already said, but preserve. And these are many actions that you can tailor for a country, or that every country can tailor, so as to find areas in which you can act to improve the brain health of your citizens. You can act at the level of policies, you can act at the level of protection and prevention, and you can act at the level of individual education of citizens and empowerment of citizens, so as to all together achieve brain health. In Italy, I just want to make a mention of my original country. We are one of the 5 European countries that have been launching a national brain health campaign, and we launched it on March at the Parliament, involving all the societies dealing with neurology, from child neurology to geriatrician, as well as to general practitioner. And the framework for brain health, it is in fact encompassing many areas, not only the areas in which usually doctors work. How can you enhance the well-being of your patient? How can you think that the action of the health sector can provide and can produce social and economic benefits? I think that the framework for optimizing brain health is not only then thinking on patients or those that could be potential patients, but thinking as a role as main actors that we can all have as brain health ambassadors, in a sense. And to understand what we have to do, on the 8th of July, the WHO has been helping the global community by releasing the Intersectoral Global Action Plan Implementation Toolkit. I think it is an important tool that can help and is showing some differences. One difference I want to underline is that at the second year of the release of the WHO GAP, the importance that WHO is providing to all of us is that this implementation toolkit is, in a sense, not for all the stakeholders. It's designed for ministries of health. This is a big change from the IGAP and the implementation toolkit, because the focus of the implementation of the IGAP, is for everybody, for all the actors. Here, the WHO is asking all the actors to work so as ministries of health are able to design and plan things and actions for neurological disorders. So it's a bit a switch from the WHO Global Action Plan, but it is refocusing the work of the international community in a manner that is very much clear, because it takes the 5 points of the Global Action Plan and is giving point by point lines of actions. I will not focus on all the 5 points, but what is the today's point, which is prevention, promotion of brain health and prevention of neurological disorders. In the implementation of the strategic objectives, which is now chapter 5 in the toolkit, this is chapter 5.3. And I just go towards the end of my talk presenting what are the suggestions of the WHO for the promotion of brain health and prevention of neurological disorders. First of all, the idea of promotion of brain health, it is something that is going throughout all the lifespan of people and is related to minimizing the risk and increasing the protective factors. Of course, we need to learn how to speak about physical health and physical activity, healthy environment, safety and security, as well as learning and social connection, as well as access to quality services, which is a bit beyond the work of the single doctor, the single neurologist, but is very much impacting on how big societies like the WFN, the WFNR, or the European FNR should work within their stakeholders. And prevention is not only the preventive services of neurological consequences of communicable diseases, which is very much for low and middle income countries, certainly very much affected by diseases such as still tuberculosis, malaria, as well as other viral diseases, but it is also preventive programs to control risk factors shared with other non-communicable diseases, physical inactivity, hypertension, poor diet, alcohol, and tobacco. Why it is important prevention? And I think we have to educate also our own members in the big societies and federation, because the holistic perspective of health that we are requesting to our members, it is something that goes beyond just being a very good expert in your own discipline. It requires something that makes the doctors and the health professionals think into the benefits for society when promoting brain health, because not only prevention can reduce the burden of new emerging cases of neurological disorders, but also it is reducing comorbidities and mortalities, which is something we don't speak so much enough. And many neurological conditions can be prevented. We never discuss enough this point, and I think we have to learn, and maybe universities and academia should go more in depth. It is well known for stroke, but it is not as much known for other disorders that can benefit from prevention campaigns. The WHO in its toolkit is telling us that we need to have an intersectoral platform with integrated policies. Are we discussing this with our member countries? Are we discussing where is the place for neurology and neurological diseases towards taking some of the actions already in place by governments to reduce the key risk and protective factors and applying them to the reduction of neurological diseases? Intervention should focus on increasing opportunities for people so as to increase the brain health at all ages, as well as thinking to the issue, for example, of environmental health and neurology, something that is very much part of the brain health as such. There are many policy actions. I'm not going into detail to all of them, but I think that I am interested in the second policy, which is also connected to implement fiscal policies on unhealthy food and beverage, alcohol, and tobacco, so that you have some healthy lifestyle benefit. Thinking in this manner is very much for politicians, but it is where also professionals should learn how to use. And in the last point, it says that one brain policy should be incorporated on a One Health approach, which considers together public health, but also the environment of animals and plants, to implement the programs and policies, considering that we human beings live in a context, and this context is interacting as a barrier or as a facilitator for us. I think it is interesting that most of the prevention of the toolkit is related to the children. It's recommending routine newborn screening for neurodevelopmental and neurometabolic disorders. It's asking to promote perinatal care, and it's asking to introduce the prevention of neurological disease for infectious diseases, and emphasize the importance of vaccination for prevention of disease through campaign. We do not usually have this in mind when we speak about prevention, but this is what WHO recommends to reduce the burden of neurological diseases worldwide. Where it is most interesting, the toolkit for all of us, it is in the raising awareness part, where it is asking all the societies and people to promote brain health messaging and brain health promotion messaging and initiatives. I think today it is one of the raising awareness initiatives that are supporting this WHO effort to increase the awareness, the global awareness about brain health. But also the WHO is suggesting that also the evidence-based curriculum in the academia, whoever is dealing with brain and neurological diseases, has to have in the education sector in education on brain health promotion. As well, the idea that you can take care of the brain from early phase, from pregnancy up to the end of life, so a lifelong approach, is what WHO recommends. Last but not least, in the prevention area, in how to reach the objective, the WHO is also emphasizing that we have to do research on social determinants. And I think Volker Homberg has been expressing what we as WFNR are trying to do to prevent. We are working and we are trying to work on all the determinants of bad brain health to make them from barriers to facilitator. And also, I think WHO is providing, and I'm going to end, a series of tools and resources that are available and free for everybody to use. So just to close, I'm saying that we at the WFNR have been collaborating for the past years, since 2012 with the WHO Disability and Rehabilitation Unit, and since 2020 with the WHO Brain Unit, try to have our role as a support for this big campaign, for this big neurology revolution. And I think that it is in this spirit that we participate today in the World Brain Day, hoping that we, together with all the citizens, can be together working for a better health, because we are all working for better brain health. Thank you.
Okay, thank you very much, Matilda, for this survey on the current status of the IGAP project. What I see is that if we look at the toolkit now, rehabilitation is not very well represented on it yet. So we certainly have to work on this and stress have more emphasis on this, which I think certainly is very important. And within the next year or so, we have to really make us more visible in this respect. One element of this is to define what is minimally needed for a good rehabilitation system. I mentioned earlier, we will be tremendous difficulties in going for the let's say typical classical type of rehabilitation strategies, which have been developed more or less in rich countries around the world. And let me have a short look at the chat room. Unfortunately, I don't see anything in there. So, Matilda, I'm sorry to say, no questions to you. Probably have been too clear on this respect. But in any case, to all of you listening, I think all of us are all times happy to get information from you by email or whatever, directly to us or to our office in Tracy for WFNR, if there are any questions or if you want to get engaged in one or the other initiative. As I mentioned, one important aspect, of course, is to define a sort of requirements for rehabilitation, which, of course, also have to be matched with neuroeconomic possibilities, resources, and so forth. And I'm very glad that our dear friend Sabah Azimvasti is joining us today. He is a neurologist and PMR doctor at the Cleveland Clinic in Abu Dhabi. He is the regional vice president of the WFNR for the Gulf region. And for some while, he made up his minds very nicely on the idea of minimal requirements for some aspects, at least, of rehabilitation and stroke, TBI, and other disorders. Sabah, great to have you with us, and go ahead.
Thank you very much. Can you hear me and see me?
We can see and hear you.
Wonderful. I don't know whether that's a blessing or not.
Well, no. Well, and also Sabah is a poet as well, so
That's right.
Listen carefully to his phrasings. Yeah.
Thank you. Thank you very much. Thank you very much. I think this is a very wonderful gathering to discuss some of the very complex issues of our practice. And one of the biggest complex issues is with the rehabilitation interventions, so I wouldn't say poorly defined, but so vastly defined. And the elements of the service are so sort of wide-ranging that it is very difficult for people to set up good services with a good understanding and put in the standards and the interventions that are most required by the patient. So this is sort of the thought process that took me to think about what can we do in order to fill the gaps that exist currently in the field of neurorehabilitation. Now, it is a World Brain Day concentrating on brain health. And thinking of the brain health, we have to keep injured brain healthy as well after they have been insulted with whatever, the brain trauma or the stroke or what have you, as much as we have to keep the healthy brain healthy. So that's the concept that you have to take in your mind when we go. And I was given this, to take you through some definitions to understand what this whole concept really means. So neurorehabilitation services as we are today are not standardized. If you go to 10 different neurorehab units, you will find that the number of therapists will vary in each one of them. They're not going to be, even if they're serving 100 patients daily, their number of therapists will be different. There'll be a different number of therapists for physio and occupational therapists, and the ratios are not properly defined. They're structurally and operationally variable. You will see different kind of machines in the gym. You will see different types of equipment that is being utilized, and you will see sort of somewhere there will be continence service, in another one there will be no continence service. So the structurally, operationally, they are, and the layouts of the units are very variable as well. Some have small rooms, others have large rooms. Some will have hydrotherapy pools, the others will not have hydrotherapy pool. So there is a major sort of variation in the facility and the services that are provided. The interventions and the treatment for similar impairments may be different from facility to facility. So you don't have that if a person has a flaccid right upper limb paresis or paralysis, you will give X number of sessions of this type of physical therapy. So you don't have those parameters defined where the occupational therapy and the physical therapy will work together. When there is an associated speech impairment, what happens about the communication component for that? So there is a huge disparity in the way the interventions are offered. Then there is a disparity in availability of resources, expertise, and equipment. So some neuro-rehab units you will go, and if you ask the physical therapist, were you trained in doing stroke rehab? They will say, oh, no, we had a general physical training and then we came into this unit to work. So there is no emphasis on how much sort of specialization we will want a person to have before they start working in a neuro rehab unit. As I already mentioned, you don't know what is the per patient cost that should be afforded to a neuro rehab unit for a given condition. And then we have already mentioned the equipment. The standards of care are not optimized. We know that. And this is worse in the lower and middle income countries who look to develop the services as higher interest countries, as most of the research and evidence based originates from these countries. And it is difficult for them to do so. However, they cannot match the resources, and hence are both in terms of trained staff, money, and the facilities that they develop. They cannot match them, and hence are unable to establish even fair to middling level of services. So this is the concept that led us to think about what should we be doing in order to at least have a little go at sort of standardizing or developing some sort of level of care that should be offered to patients with neurological disorders. So the concept is that if we can, as a neurorehabilitation specialist, define and make recommendations for minimum requirements, standards, and interventions, this may help wider range of healthcare providers to plan and develop neurorehabilitation services. This exercise should remove some of the barriers currently faced by providers of neurorehabilitation services. That's the concept, and this is the way we are trying to push this task forward. So what is a minimum requirement? Before we actually go ahead, and I think we have abstract concepts in our brain, what the minimum is and what a requirement is. But in the context of healthcare or a service development, a minimum requirement refers to the essential and basic criteria or standards that must be met for a service to be considered acceptable or functional. So these two words, acceptable and functional, are important in a neurorehabilitation service context. Such requirements set the lowest level of acceptable performance or capability and ensure that the essential elements necessary for proper operations or compliance and outcomes are in place. So these are the two basic things that we think about when we talk about the minimum requirement for service to be developed. This leads us to the discussion of what is a minimum standard. The term minimum standard is often used to describe the least permissible condition, and this is the or procedure required to demonstrate a basic level of performance. So if I may, that you will not take a stroke patient in my city now to a hospital where there is no TPA availability or possible thrombectomy possibility. So that has now become a kind of minimum standard for stroke care in Abu Dhabi. And I think this is what we should be doing in neurorehabilitation as well, because whilst the patient may go with a stroke to a place where they can do TPA, that hospital may not have the capability of then after the TPA to provide decent neuro rehab. So this is the one thing that we may have to discuss at the WFNR level for us to recommend that if a person has a stroke, which kind of hospitals they should be taken to and where they should be provided the initial treatments from rehabilitation perspective and the subsequent ones. And then what treatments should be given? What is a minimum intervention? A minimum intervention refers to the least amount of degree of action, amount or degree of action or treatment required to achieve a desired outcome or to address a problem effectively. This concept is applied in various fields, including healthcare, education, and environmental management to minimize risks, costs, and disruptions while still achieving necessary results. So we have to sort of, this is a large task of what we are proposing to do, and we will talk more about this in a bit. We would like to utilize it for defining neurorehabilitation programs for patients with various neurological conditions. So just keep those things in mind. The minimum requirement for the facilities need to so minimum requirements in the if in the context of a service plan for a neurorehabilitation service, minimum requirement will need to be developed an operationally satisfactory facility or service. Minimum standards are needed to have that facility operate the service satisfactorily on day-to-day basis, and then minimum interventions need to intervene with an intention of securing a positive or favorable outcome for your patients whilst you are adhering to the minimum standards. So that is a sort of concept or an abstract concept that exists in my mind at current time. So what is a minimal intervention, or there is a concept that we would talk about is minimal intervention needed to change and what is the rationale for that? So numerous effective interventions are available, but not widely or equitably distributed. Low-income populations and low-resource settings face challenges in finding the time, resources, and infrastructure supports necessary to produce successful outcomes from intensive interventions. Manpower and suitably trained professionals may be difficult to access to effectively deploy interventions, and thus many existing evidence-based interventions have low or limited reach among individuals, patients, and reduced adoption by the clinical and the public health setting. So if you think about it, one of the proven intervention is constraint-induced therapy, and I can ask you to send your a questionnaire out to many rehab facilities across the world, and you will see that the uptake is really, really low on that because of not being aware of it, number one. Number two, not having trained therapists to deliver the treatment, and not knowing how how long the treatment needs to be done and who the treatment should be provided to. So this lack of knowledge, lack of expertise is a big problem in disseminating proven treatments even for patients with neurological disability, particularly stroke and brain trauma. So there's another concept of comparative effective research. There's a number of interventions that have been shown to be effective, but it is often difficult for consumers, practitioners, and researchers to know which is best and to distinguish any meaningful differences in outcomes and cost effectiveness. So these concerns have in part given rise to comparative effectiveness research. So an example of a sort of comparative effectiveness research is that aspirin is widely available, minimal, it is a kind of minimal intervention, it is low cost, and it is an effective intervention. A pragmatic CER perspective suggests that more expensive, intensive, or aggressive interventions should be proven to be more clinically and cost-effective than aspirin to be recommended for use universally. So, in the last several years, you have seen other medications, antiplatelet drugs, come out like clopidogrel, otherwise called Plavix or Brilinta, but they are more expensive. If you look at the box of aspirin, it costs you almost, in my town where I am, 2 or 3 dirhams, which is less than $1, as against Brilinta, which costs you about 400 dirhams or plus that, which is about $40 or $50. So if you look at the comparative results, you might find that aspirin, both in the cost effectiveness and effectiveness, is a reasonable choice to give to wider population. And that's why for the long-term maintenance, aspirin is the drug of choice. So this is a comparative effectiveness research that we are talking about. It is a minimal intervention and widely used in cardiovascular and stroke prevention regimes. So the cost effectiveness research strategy for identifying effective interventions is based on the concept of minimal intervention needed to produce change, or MINC. This, I think, is a very interesting paper. I will refer to you to have a little look at it. It was written or produced by Robert Croyle in a personal communication in 2010. And I will be happy to give you the link to this if you so wish to read. MINC is defined as the minimal or lowest level of intervention intensity, expertise, and resources needed to achieve a clinical significant improvement in a specified outcome for a particular target population under a particular set of conditions when delivered by a specified type of staff or interactive modality. So that is the core of what the task we shall be doing. We need to be adhering to that kind of concept. What is the minimal intervention that you require for X impairment in stroke or in brain injury or spinal cord injury to achieve what level of improvement? So this is something, it's a very hard task, but it nevertheless needs to be addressed in order for us to give guidance to people how to actually deploy the staff and resources for their patients. The goal is to provide an anchor or standard to help compare different interventions to determine the relative improvements based on their relative costs. And by defining the minimal intervention needed for change in a given content area, it is possible to identify the least costly, easiest to administer interventions that are most likely to be disseminated. So this is the core principle. We want wider people to actually have access to treatments that are be effective and of low cost. So this is the basic core principle that we are working at. So what are the future tasks that we have? This is my last slide. Develop a task force to work on minimal requirements for the facilities, minimal standards for that facility to run on, and minimal interventions in neurorehabilitation for the people to be able to get right kind of treatment at a low cost that are at least effective and to a certain extent alleviate their possibility of reduce the possibility of evolving into a disability, the impairment evolving into disability. So this exercise that we are going to enter into, which is an ambitious exercise, I admit, is minimal recommendations for facility setup, minimal standards, condition-specific standards like how to set up services for stroke or brain injury or spinal cord injury or multiple sclerosis, or etc. As we go along, each set conditions can be developed. And a set of minimal, this is the largest body of tasks, a set of minimal interventions, impairment and domain, which should be impairment and domain specific. So we, for instance, we should have a minimal standards for management of dysphagia, and also a list of minimum interventions, how to manage dysphagia in the first week, in the second week, in the 4 weeks, or in the first 3 months or 6 months, or what have you. Similarly for dysphagia, similarly for motor impairments, perceptual deficits, cognitive impairments. So this is the most if you may, ambitious task that we will be undertaking. I think that our plan is to go condition by condition and pick up a number of impairments within each condition and evolve the go along depending on the. Now, the one of the things that we will do is not going to dwell too much on the available evidence, because I think we, in a rehabilitation environment, fraternity, we know that our evidence is still to be brought forward through proper research, and because of our methodologies are such that really does not allow for us to bring out the right evidence for right interventions. So that is where we are, and I'll be happy to discuss it further because it's a kind of very huge discussion topic. But anyone who wishes to join us in this ambitious task is very welcome to, and I'm there. Thank you for your attention.
Yeah, thank you very much, Samad. I think this concept of minimal requirements associated with cost effectiveness analysis will be extremely important, especially in our formulations for the fueling in into rehabilitation aspects of the IGAP. But even beyond that, I think it's absolutely important that we think about what is minimally needed, also following the idea to convince decision makers, politicians, and so forth, what should be done. And I think we have to work on this. And as Sabat already mentioned, we are just forming a task force for these minimum requirement definitions associated with some, let's say, health economic underpinnings of this as well. And everyone from the audience who is listening to us now is cordially invited. If you have an interest, just let us know. Use either Sabat or my email or our general email at the World Federation, and we are happy for everyone who would like to contribute on that. It seems to be a little bit. We speak about minimal requirements, and some people may have the impression that's too parsimonious and it's not ambitious enough to do it. But nevertheless, as I mentioned, we are faced with a situation that the majority of people in the world will not have access to the usual standards, and we have to do something about that. And I still do believe that also digital technologies may help us, and will certainly also blend into this definition. So, from our friends from the panel, are there questions to Sabat? I don't see anything in the chat room.
There is a hand up in the chat room by Andrew Kerr. I don't know whether that's.
There's someone, Ellen Rathagen. She says that she wants to be counted in, but there was someone raised his hand. That's right.
Is that a hand in for joining?
Andrew Kerr, right? Andrew, go ahead. Can you hear me? Andrew, you're muted. It's difficult to speak when you're muted. Right? Nonsense. Yeah.
Turn your mic on.
Andrew, could you put your mic on so that we can eventually take your question or comment? Doesn't work.
Maybe if he cannot do it, he can write the question.
Okay, go ahead. Okay. So, Andrew, eventually later. For the time being, any other comments from the panel? Not at the moment. So then I think we can go on. And the next speaker will be Professor Mayowa Valabi from Nigeria. He's the Regional Vice President for Sub-Saharan Africa for the World Federation, has a long, many years of experience and engagement in many aspects of public health in Africa and neurology in Africa. And today he's going to talk on community-based rehabilitation projects. I mentioned that earlier as one of the core pillars we expect future developments to be guided. Okay, is Mayova with us at the moment? Can you hear me?
Yes, I can hear you. I actually sent my pre-recorded presentation.
Okay, we can. If you don't mind,
Just
Mayova,
play.
we will play your pre-recorded
Yeah.
video now. Chris, yeah, we'll do that. Yeah.
Absolutely. Thank you.
Happy World Brain Day. I want to thank the WFN and the WFNR for organizing this webinar to commemorate this year's World Brain Day with the theme Brain Health and Prevention. I'm privileged to be talking about community-based rehabilitation. Neurological disorders are the leading cause of disability adjusted life years across the globe. And amongst NCDs, which currently constitute the greatest cause of deaths, accounting for 7 out of every 10 deaths, the fastest growing cause of death among NCDs is neurological disorders. And if we pick just one of them, which is stroke, it costs about $900 billion per annum, while dementia costs about $1.3 trillion per annum. And the increase in the number of deaths due to neurological disorders in the past 30 years has been over 40% increase, and this continues. So 1 out of every 3 people at risk of developing neurological disorders, and neurological disorders are often associated with disability. Among the neurological disorders responsible for disability, the top 37 of them are on this slide, but I'll just mention the key ones like stroke, neonatal encephalopathy, migraine, dementia, diabetic neuropathy, meningitis, epilepsy, preterm birth, autism spectrum disorders, nervous system cancer, Parkinson's disease, neural tube defects, encephalitis, and so on and so forth. Across the life course, you will see that in the early years is neonatal encephalopathy, and then followed by meningitis, then followed by migraine and other headache disorders, and then stroke, and eventually dementia. If you look at the burden in 1990 and 2019, you see that most of this burden is borne by low and middle income countries located in Africa and Asia. So a neurology revolution is required to reduce the burden of neurological disorders and to improve the life and quality of life of people living with disabilities across the globe. But also, it's very important to also prevent the occurrence of neurological disorders, which is the theme of this year's World Brain Day celebration and commemoration. So global synergistic actions are indeed needed to improve brain health for human development. And this is because without brain health, there is no health, and without health, there is no wealth. All the SDGs depend on good health, and good health depends on brain health. It's because brain health determines physical and mental health, social health, planetary health, and spiritual well-being. Rehabilitation is one of the 4 cardinal pillars of the neurology quadrangle. And rehabilitation, of course, includes realization of potential, re-enablement, resettlement, role fulfillment, and readjustment. Rehabilitation requires a holistic model that is multidisciplinary, that involves assessment, evaluation, planning, setting of goals, therapeutic intervention, which is usually multidisciplinary, and then, of course, eventually evaluation of the impact, and then planning and setting goals again. So essentially, rehabilitation intends to add years to life, but not only that, add life to years, improving functioning and quality of life, and of course, more importantly, add meaning to life, and engaging the individual with neurological disorder to self-realize and self-actualize and live a meaningful life that contributes to society. So the world is waking up to ensuring that this happens through the Rehabilitation 2030, a call for action by the WHO, and is aiming also to tackle the LMIC conundrum and ensure that rehabilitation is included in the continuum of care, and targeted disease-specific approach is also incorporated with the package of rehabilitation that was also launched by the WHO. So package of interventions for rehabilitation was recently launched by the WHO, including for neurological disorders. The major issue, of course, is that low and middle income countries, which bear most of this burden, have the least resources, not only in terms of financial resources, but also in terms of manpower and personnel that is required to deliver the care that is needed for surveillance, prevention, acute care, and rehabilitation of neurological disorders. So, unfortunately, the health sector is grappling with poor infrastructure, poor funding, and human and, of course, inadequate number of personnel, and in fact this is worsened by brain drain, and out-of-pocket payments is also dominant. So an economic model that is required to ensure that there is access across the globe, particularly in low and middle income countries, we need to talk about increasing supply in terms of increasing the workforce, facilities, equipment, and tools, and the variety of settings in which rehabilitation can be delivered to the multitude of people who require this service. To reduce price, of course, would mean increasing supply and reducing demand. To reduce demand, of course, would mean reducing the burden of disease through prevention, and that is one of the cardinal pillars of the neurology quadrangle: surveillance, prevention, acute care. This can reduce the burden. But also, we actually want to increase demand for those who already have this condition, because it's paradoxical that many people are not even aware about neurorehabilitation among the large number of people who have neurological disabilities, and they actually do not demand for this, particularly in LMIC. So demand needs to be increased for those who actually need the service. It's important to promote affordable and accessible pragmatic solutions, innovative smart solutions, increased workforce, task shifting, task sharing, community-based and tele-rehab combinations are very important to ensure that access is provided. So there are different settings of acute rehab, and community-based rehab or home-based or tele-rehabilitation. And usually this happens when the individual no longer requires inpatient care or outpatient care, or in between outpatient services, community-based or home-based or tele-rehab can offer an avenue to continue care and to ensure that the intensity, duration, and quality of care is maintained between formal care in the hospital. So there is it's like a pyramid. At the end of the day, the individuals are going to be returned to the society, and that is why home-based and community-based rehabilitation is important, particularly for long-term and sustainable rehabilitation, because recovery continues. So some of these settings are already presented in the clinical pathways in stroke rehabilitation as an example, which is available. Now, community-based rehabilitation is not new, was initially mooted by the WHO since the 1970s, and now it has become more important in the last few decades as an avenue to ensure that more and more people who require rehabilitation services are able to get this care. So essentially, what it does is that it's a whole of government, whole of society, multi-sectoral approach that we are all in, and that people living with disabilities are in the communities, and we want them to recover fully, to be reintegrated back into the community and to participate in community activity. So essentially, the concept of CBR embraces creating a positive attitude, providing rehabilitation services at the community level, providing education and training possibilities, generating opportunities, mainstreaming people living with disabilities, and ensuring self-employment, awareness creation, and advocacy, and of course prevention of causes of disability. So it means we are all in it. So it also encourages support, love, and care for each other. So the WHO has done a lot on this in the past few decades. And it's a community development strategy that aims to enhance the quality of life of people with disabilities and their families and ensure their inclusion and participation in the community. It uses a grassroots approach. It's a strategy for improving the quality of life of people with disabilities by changing the work of the various services for people with disabilities in order to best meet their needs, ensure their equal opportunities, and protect their rights. So why implement CBR? Well, there are benefits to the community. It fosters more positive attitudes towards people with disabilities, dealing with stigmatization issues, and promotes the inclusion of all people, particularly those with disabilities, in the work process as well as recreational activities within the communities. To ensure that people with disabilities are seen as able, maximize the physical and mental abilities of people with disabilities, improve access for people with disabilities, and enable them to become active contributors. So this is an example. On the 2nd of December 2022, there was a WHO Global Report on Health Equity for Persons with Disability. And lo and behold, the moderator, Abin Garma, was a deafblind person who was actually the first deafblind student to go to Harvard Law School and moderated the event seamlessly and gloriously to the chagrin of everyone. So there is ability in disability. So the principles of CBR are based on those of the Convention on the Protection of the Rights of Persons with Disability. They are part of, and that they should be viewed as part of human diversity and humanity, and they should be empowered without any discrimination. So community-based rehabilitation matrix looks not only at health in terms of promotion of health, in terms of prevention, which is the theme for this year's World Brain Day celebration, in terms of providing medical care and indeed rehabilitation at the community level, assistive devices, but it goes beyond health into community reintegration through education, particularly those who have neurodisabilities in early childhood should still be able to get educated, go to primary school, secondary school, non-formal education, learn skills, vocational skills, and then livelihood. We also want them to have skills, not just education, entrepreneurship, be able to employ themselves, be able to be gainfully employed, in fact, employ others, and also have social protection and financial services. So they also will need assistance, relationships. We want them to be integrated into families, get married, have children, participate in culture and arts and recreation, and be and be fairly treated by the justice system. And more than that, actually be empowered through advocacy, community mobilization, political participation, and of course, self-help. So the CBR matrix is what I've just presented. And the 5th component relates to the empowerment, which I had described in detail. So CPR program is really a 24 hours a day program because every day life goes on for 24 hours. And where is the best place to offer this? Of course, the best place to offer CBR, which is economical compared with specialized assistance, where of course there could be more coverage is provided. There is no need for specialist professionals. Simple, effective technologies empowers the family and the community. So of course it's in the community where this can be provided. So community level, 70%, because people are going to live in communities at the end of the day. So we illustrated this for stroke in the Lancet Commission on Stroke. We can see the 4 pillars again: surveillance, prevention, acute care, and rehabilitation. Rehabilitation is the 4th pillar of the stroke quadrangle, and it's also the 4th pillar of the neurology quadrangle. So it's important to use a whole of government approach that do not only look at motivation and capability, but also opportunity. And for stroke rehabilitation, multidisciplinary rehabilitation services is important, innovative low-cost interventions, improving quality of life, and it's important to investigate the feasibility, safety, effectiveness, and coverage of home-based rehabilitation, including self-management and community-based rehabilitation going forward. Family can offer support, but of course, we have to look at caregiver burden as well and not belabor the family with stress that is more than what they can bear. But family certainly is important as part of the caregiver to support recovery. Functions of family members, active participation in all stages of CBR, voluntary participation, clarifying disability issues, and of course, education. So specialists or paraprofessionals. Specialists have a narrow knowledge and are prepared to protect it. Rehabilitation involves many repetitive parts, which can be done by relatives and not necessarily by professionals, provided, of course, that the relatives are protected against excessive caregiver burden and stress, and that they are able to do some of these activities under supervision, thereby telemonitoring. So family members can participate, and that removes barriers that may prevent persons with disabilities and their families from participating in community life. Civil society and relatives organizations can also help promote community-based rehabilitation programs by providing facilities in communities and by providing educational facilities as well. Policymakers are also very important to facilitate this. CBR staff would include the rehabilitation committee, coordinators, family trainers, and of course, people with functional limitations must also be included in the matrix. CBR staff identify persons with disabilities in the community. They provide the simplest therapeutic interventions in a safe environment. They train family members on how to support and assist people with disability. They provide information about services available. They refer to specialists and provide follow-up monitoring whenever required. It's community-based rehabilitation is not isolated. It's supposed to be integrated into the continuum of care to ensure that whenever the individual requires outpatient care or inpatient care in a rehabilitation facility, such individual is referred without delay. To promote the formation of mutual aids group, those are some of the things that CBR staff can do, and they can be paid by government. So the rehabilitation committee in the communities should include people with disabilities and their families, people who provide professional help, including teachers, doctors, social workers, and the concerned members of society. So approaches to promote CBR includes providing the therapies that is required in community-based setting through task shifting, task sharing, but it must be supervised and it must be safe. It's the simplest forms that can be done safely in a repeated manner. Low cost, effective, pragmatic solutions. We need research into this and locally produced assistive devices. Enlightenment is important, including using video, applied theater, phone apps, and so on and so forth, and social media and tele-rehabilitation. Advocacy, which WHO has been doing, Ministries of Health, African Stroke Organizations, and other organizations, WHO Lancet Commission, and many regional action plans for domestication of the WHO Intersectoral Global Action Plan. Then training is important through webinars like the one we're having today, workshops, conferences, and so on and so forth. So rehabilitation pillar is the worst hit, so to speak, in terms of lack of services across the globe. And that is why community-based rehabilitation may be one of the ways for providing access. So, and it's been shown that community-based in primary healthcare centers, as well as domiciliary, are effective. So, but a global ecosystem is required to eventually implement this, that involves providers, policymakers, patients, payers, the general population. So these are some of the activities on the African continent which promotes neurorehabilitation, including community-based rehabilitation. And we are going to be having the African Stroke Organization conference, the fourth in the series, in Zambia, and you are all invited to be part of this. We have some funded postgraduate training programs to promote neurology services and training, as well as brain health across the globe, particularly in Africa. So that is the CBR matrix once again. And the essence of rehabilitation is to ensure that individuals are able to live a fulfilled life where there is a convergence of their passion with their mission, profession, and vocation. And some of you will be invited to join the Lancet Commission on Rehabilitation, which is also going to promote brain health as well as all the 4 pillars of the neurology quadrangle: surveillance, prevention, acute care, and of course rehabilitation, specifically including community-based rehabilitation. So hopefully in 2028, we will be hosting the World Congress on Rehabilitation in Africa. Thank you so very much for this great opportunity, and continue the celebration of World Brain Day by preventing damage to the brain and improving brain health across the globe. Thank you so much.
Thank you so much, Mayova, for this very nice tour through all the many facets of community-based rehabilitation, which certainly will be one of the major strategies to be followed in future. But you've seen it's more complicated than thinking of it just from the beginning. It needs certainly a lot of thinking, how to create that depending on what area of the world you are, how it can be done in the most effective way. We will certainly look forward to that. Let me have a look. There were some questions coming up to me that people didn't have a chance to communicate with us directly. Christian, I do not know if that has been solved in the meantime. I know Ellen, for instance, wanted to put some questions and comments, and I do not know if this is possible now. Otherwise, you should use the chat room to place questions or comments.
Chat is active all the way down, so we can.
The chat is active, isn't it? Yeah.
Absolutely.
Yes, it always was.
It always was. Yeah. Okay. So we will see. Otherwise, if you unfortunately do not get access to us directly, we have to postpone it. And we, of course, all the speakers are happy to answer any questions, whatever, on email or by other means. Okay, so I think I will go on with the program. Wayne, by the way, can you stay for a while, or have I changed the sequence to some extent? Wayne, can you hear me? Okay, so never mind. We go on with the next speaker in the original sequence, which is Professor Nirmal Surya from Mumbai in India. He is the new Secretary General of the World Federation, a very extremely active person for WFNR. And he has a long history dealing with epilepsy. And epilepsy is seen in the Intersectoral Global Action Plan as also one of the major targets. And Nirmal is going to talk about implementation or rolling out of concepts for epilepsy treatment. So, Nirmal, please go ahead.
Thank you, President, sir. It is very kind of you to introduce me today as Secretary General of WFNR, and I'm just going to say what we have developed and how we have developed a comprehensive epilepsy program, particularly for the rural area. So I would be presenting in next few minutes about the program which we have rolled out in Maharashtra, along with the government of India, which we are working for last, say, 14 years. And along with that, I will come back to the competition by the Indian Federation and WFNR on World Brain Day for the students and the rehab specialists, and the results to be announced from those competition. So what is the impact of epilepsy? More than 50 million people worldwide, out of which 80% remain in the lower middle income countries.
By the way, can you see the
75%.
next slide?
Sure, yeah, absolutely. Okay, will do. Okay.
There is a, am I audible?
Yeah, I got it.
Yes, we can hear you, Professor Surya. Yes,
Thank you. Thank you. And you are able to see my screen too.
yes.
Thank you. So as I was speaking about the epilepsy, which is a very common disease, and particularly in the lower middle income country, it has got serious issues. It have a greater risk of premature death. And the most important thing is there are a lot of stigma and discrimination. And you could see that these are the real picture taken in a couple of months before in one of the camp post-COVID. I have never seen such kind of patients pre-COVID. Obviously, it shows that when they were off the medication or irregular medication because of the COVID, which has affected their regular supply of medicine, particularly in rural area, you see kind of uh, pathology because of the seizure in these patients. Epilepsy Foundation is the one which is a NGO, and it has been working for the people for the epilepsy. And this is the prototype which model which we have made, and this is between Epilepsy Foundation and the National Health Mission, Government of India, which is working in a public-private partnership. And the blue color indicate that these are the responsibility of Epilepsy Foundation, and the pink color indicate that these are the responsibility of the government. And wherever both color emerges, that means we are jointly responsible to develop and work together. So we have developed a free epilepsy detection and management camps. We have developed an online epilepsy management system. We have developed a method to do the follow-ups. We are establishing the regional epilepsy center. We have developed a method for free epilepsy surgery. The Epilepsy Foundation provides neurologists, pediatric neurologists, pediatrician, EEG technician, therapists, both physio, speech, occupation, counselor, and social worker. Epilepsy Foundation provides the free EEG services and therapeutic drug monitoring and accreditation of the CME, which has been done there. We also provide street play awareness campaigns through the audiovisual posters and provides the mobile app. And the government ensure that infrastructure at district or sub-district hospital is given with a specialist and medical officer. There are school health worker, nurses, paramedical officer, pharmacist, lab technician, data entry operator, RBSK coordinator. They all are present. There's a free blood test, free MRI or CT wherever it's available, and the free anti-epileptic drugs are being given. We also see that media and the politician are equally involved in the district along with the services of the telemedicine. So it was the first, we started with the sensitizing workshop, and you could see here the whole health ministry, health minister, the state health minister, the health secretary, the commissioner, everyone wanted this project to be start in the Maharashtra, and we sensitized the physician across the Maharashtra. And then we also got school health worker who are the one who look after the schools, and there they can find out the children who are suffering from epilepsy to be brought into the camps and get the proper treatment. So we sensitize them how to pick up, particularly like absence seizure, the tonic and atonic seizures, and other kind of epilepsy, and plus also train them how to give the primary care, primary attention during the epilepsy. So after that sensitizing workshop for both physician and this, we started a camp. And this was the Government of India notification where the Epilepsy Foundation was given a pilot project to run the epilepsy camp. And these are the 7th camp which we started in 2011. And this was the first camp which was inaugurated at that time by me and the Dr. Rathore. We also got a clear-cut guidelines from the Government of India. And the guidelines include that how would we getting the things. Government would be spending nearly 4,20,000, which comes to about $5,000 for 1 day camp. And these are the people who will be there. There were travel allowance, their food allowance, all would be covered, and the medicine to be given. So everything was given as per the direction from Government of India. And we managed how do we go about if we go to the camp and we don't have medicine. So we ensure that government gives 3-month medication free to each and every patient. And these are the 9 anti-epileptic drugs. Most of the country in India, the anti-epileptic drugs are only phenytoin, phenobarbital, carbamazepine, and at some places sodium valproate at the district or sub-district hospital. But we ensure that patient gets oxcarbazepine, clobazam, topiramate, and lamotrigine, divalproate, along with 4 other drugs which are primary drugs. So 8 drugs were part of it. We also ensure that the government scheme includes the epilepsy surgery as a part of the project. The team would consist of all these people which I told you. So in a camp, there would be about 5 to 40, sometimes 50 team members being there to take care of the camp. And you could see the responses which we received from the camps. There are 1,000 patients would be coming for each camp, and these are various different camps. This was one of the latest camp which we did a couple of months before, where we had about 550 patients from about 300 kilometers from Mumbai. And till 2024, we have already done 106 camps, of which we have seen more than 35,000 patients. The EG of 4,750 has been done free. The counseling is done for 2,700 patients, physiotherapy for 2,600, occupational therapies for nearly 4,000 patients, speech therapy also for nearly 3,000 patients, and the CT MRI free done in the camp is about 1,200, and therapeutic drug monitoring and para was done for some of the patients. These are the pro forma which we have for each and every patient has been filled up. This is the seizure card which is being given to them. These are some of the performers by the occupational therapy, physiotherapy, speech therapy, and the neuropsychologists who fill up their patients' data. We developed this dashboard where the data can be entered. This is a master's, and these are the data along with the National Health Mission, Government of Maharashtra. And this was one of the camp we tried, where there were 50th camp, where there was about 150 patients. And this is how it will give the data: age, type of attack, the EEG done, their result, and the drug prescribed. So exactly end of the day, how much medicine we have given to how many patients also would be recorded. The follow-up was done through the telemedicine at government hospital or through the epilepsy camp, which came out to the Mumbai, or we also did at various district level by the neurologists to do the follow-up of those patients who were seen during the camp. Regional epilepsy centers were established with the National Health Mission, and there are 9 regional epilepsy centers which will be established this year in a different part of the state, and they will be able to provide free EEG, free neurologists, and the regular follow-ups with free medication. This was one of the first regional epilepsy center which was established. The epilepsy surgery also was included, as I mentioned, in Rajiv Gandhi Jeevan Arogya Yojana, was part of the package. And these are some of the early patients from a remotest area of the state which got operated free of cost in Mumbai. The mobile app was developed by Epilepsy Foundation, which has been used, and this also has got Google Map, where they can go to the nearest hospital. It also remind and give an alarm that you take your medicine, and if a patient have the mobile in his pocket or the hand, and if he get a seizure, it sends the SMS to the 2 nearest people whose number has been saved. So this can help to guide the patient that if they have an emergency seizure, the information is involved. We run a free epilepsy clinic every Tuesday in Mumbai, where nearly 50 to 100 patients are seen every Tuesday. and those patients who are want to come regularly at follow-up from nearby district, they are most welcome and they come. We do the awareness during the camp, and these are the surveys of the patients. We nearly have done more than 10,000 patient survey, and we realize that some of the common myths associated with epilepsy are there. And with the awareness in past 14 years, every 5 years, we are reassessing that. And I think there is a change in awareness and about the knowledge of epilepsy during the last couple of years. We also created certain methods to reach out to the people through the awareness. We release a movie, we release the special cover with Indian Post, which helps us out to reach out to the community. We do the street play, and this is in the local language at each camp, so that they go to 4 or 5 places and do the camp, so that people know that what epilepsy is and how that should be treated. We also produce these pamphlets and cards, what should be done, what should not be done. And these are some of the posters which are put into the hospital so that people keep on seeing them, and not to put onion, shoe, or drive, or swimming restriction to be done. While in the camp, we also train and sensitize the physician. We do the CMEs in the camp, annual CMEs and teletraining, all as a part of the training sensitizing program. So this was 180 hours, 1 year telemedicine, which we did in 2016, where the more than 200 physicians were trained through the has come to my clinic to inaugurate that, and I was connected from the clinic to all the district hospital of the Maharashtra. What is most important thing is now we come to a place that while we have done this camp, how does they help? Has this made an impact? So we are doing is we take all the data, we enter them into the system, and we do a systematic monthly follow-up. And post-COVID, we have restarted now, and we give them a support via telephone and WhatsApp. And those patients who has a problem, who called up, we appropriately refer them to the nearest district hospital or to the nearest neurologist so that they can be guided. And if they are not getting the medicine, if the medicines are not available, we from the foundation provide them. And these are some of the unique patient follow-up. We started in 2018, and almost 1,000 to 1,500 patients will be called every month. And this is a virtual team who would take the call and enter into the system. And you could see that the nearly 77 to 86% of the patient started seizure-free. So they were taking the medicine regularly. When we kept on calling, they started taking regular medicine. There are 10 to 12% patient, they will not take the medicine. Improving. So it was started initial was 68%, which increased to 74 to 72%. So nearly 70 to 75% patient seizures has improved in these camps. The side effect was only to the 10%, and they were minor. The major side effect was only 1 to 2% among these patients. We would do the scanning of the papers. It takes 30 seconds in the camp, and some of the patients will send their photograph along with the medicine, that these are the medicine I'm taking, how do I do it, and we support them. So these are through the various calls, and we have nearly done for 1 year. Post-COVID, we have restarted, and what we have found is that 72.6% patients was seizure-free in the data which we received. 84% patients were total adherence to treatment, and 15% were never. And 86% a person with epilepsy did not report any anti-epileptic related drug. And some of them who had like weight loss, depression, vomiting, nausea, headache, drowsiness, and dizziness. So that is something which was very interesting. And we also asked them how much satisfied they are. And they were very, very satisfied with our services and our camp. And nearly 90% of people supported us. So this was the uh, comprehensive program which we have been able to establish in Maharashtra, and we are looking forward to this same model to be taken over in different states by the government from the various states, because this provides the free medication, free services, and at least all the patients are seen by their specialists and their diagnoses are done through the EEGs and the CT MRI. This is the team in one of the camp, which we have about 40 people in the camps to learn. So now I move on to, if you allow me, then I can announce the poster competition now. If
Sure,
I
you go ahead.
have few more minutes. Federation of Neuro Rehab, WFNR, WRA, and Epilepsy Foundation, we did this World Brain Day poster competition. And the theme was brain health and prevention. We gave the deadline to 17 July, and the winner was declared to be declared today. The first prize was 5,000 Indian rupees, second was 3,000, and third was 2,000, with 5 consolation prizes to be given to these people. We received 124 entries for this poster competition. And this was not only from India, but also from across the world. And there was total taken up for the prize was 116, as some of them was either the duplicate or there was some technical issue with them. The 2 judges was eminent judges, our member of large, Professor Tisha Vijayratne, who is also co-chair of World Brain Day, and Dr. Chandrasekhar Meshram, who is a trustee at World Federation of Neuro Rehabilitation. We have multiple disciplinary participating in this, 42 physio, 23 OT, 5 neurologists, 1 OT, orthopedic surgeon, 19 psychologists, 18 ST, 3 physiatrists, and 5 others participated in this competition. And the first consolation prize to the winner was Marlene Varghese, who is a BSLP student 2021 batch from Amrita Institute of Medical Sciences, Haryana. And this was her poster with the theme of prevention. The second winner of consolation prize is Mehak P. Singh, and this is her poster with the brain showing various activities to prevent. She is a first-year physiotherapy from Sancheti Institute of Orthopedic from Pune. The third consolation prize went to the Preeti Bhutani, who is an occupational therapist from New Delhi, practicing as private, and her concept of a tree with brain health and various concepts on this. The fourth consolation winner was Rashi Shingal, who is Masters in Physiotherapy from Sri Guru Gobind Singh Tricentenary University, and her concept was tree with the brain and how it can be protected with various concepts. The fifth consolation prize went to Harshita Singh, who is Masters in Physiotherapy from Jamia Hamdard University, New Delhi. And this is her concept of brain health and prevention. How do the brain to be taken, production and others. We also did is we gave a public choice award. So what we did is we created a QR code, and we put it to the various social media, asking people to select their best poster. And you will wonder, in 3 days, we had about 2,831 people who voted. And the maximum vote who got 291 was the winner. And the winner for Public Choice Award is Rituja Malkhande, who is MPT first in neuroscience, and she's from the Maimar Medical College, Talegaon, Pune. And this is what her poster says. It's okay not to be okay. And she's shown neuromuscular junction and the neuro rehabilitation. So this was selected by the people from all across the world. So I congratulate her. This was not the part of the plan, but we decided that we will involve the other people, the public, to participate and see the World Brain Day, how important it is. The second runner-up for the competition is Vaibhav Vikas Das, who is an occupational therapist from private clinic in Bhubaneswar, Odisha, which is eastern part of India, and her concept of watering of the brain with the various points for the brain health prevention. The runner-up for the program is Nivedita Yogesh Mane, who is an occupational therapist, and she's from a private clinic in Goregaon in Mumbai. And her concept was Cafe Brain, and she created a concept of Bollywood or Hollywood, like kids menu, 90s, and the retro, and how one need to do the brain health and prevention. I think this concept was fantastic how she has brought it out, and she richly deserved the winner. The winner of the competition is Seema Redshi. She's an occupational therapist from Tata Memorial Hospital, Mumbai. And this is her concept of brain health and prevention with multiple hands like epilepsy, depression, anxiety, stroke, and how the person should do to prevent the brain health. So once again, I congratulate all the winner, and I thank both the judges, Tisha and Chandrasekhar, who really has to go hard because there are 124 posters they have to go through. So thank you all for participating, and I'm sure you will keep on participating again and again in this sort of competition. And thank you, WFNR, for being part of it, and other organizations.
Okay, thank you very much, Nelmo.
Thank you, sir.
Also, congratulations from my side to the winners. I think it was very useful to have such a contest running through for World Brain Day, and it's going to be very successful. A lot of participants. Certainly, a great idea which we should pursue also in future. Also, thank you very much for your very nice talk on this concept of rolling out epilepsy management. I think it's very impressive what can be
Thank you.
done, especially in an area where, let's say, epilepsy therapy and epilepsy awareness was not very well functioning. And starting in 2011, now 2024, or these 13, 14 years, was certainly a very successful endeavor and let's say, blueprint for other people. And many of the concepts we discussed today, minimalization on one side, and bringing it to families and community is very much embedded in that. Let me have a brief look at the chat room just to sum it up. There were some questions in the meantime. There is our friend Ed Adams from Ghana, and he's asking what we can do to government buy-in, support the implementation of community-based rehabilitation in various countries. There's a question on the political implementation. Who wants to answer this?
Okay, let me just answer very quickly.
Yeah.
Can you hear me?
Go ahead. Yeah.
Okay.
Sure.
I think two ways of getting them interested is if it's going to be integrated into the primary health care program and universal health coverage. I think those are the two ways of getting them interested, so that it's part of the continuum of care for people living with disabilities at the PHC level. So by training community health extension workers and by integrating at least minimal interventions that can be paid for through universal health coverage. So I think that's the way to get them involved, apart from advocacy. Thank you very much.
Okay, certainly it's always an issue how to convince politicians on that, and we certainly need clever strategies of doing that. There's another question from Sana James Aragwande. Facilitators and barriers of telerehabilitation based exercise among low and middle income countries. So the question is there a scored questionnaire how to evaluate the facilities and barriers in using telerehabilitation? Who wants to answer this? Well, No, Mal, do you have an idea? Oh, he's busy at the moment.
Yeah,
Well, I can
I think
eventually.
Sabah, yeah, I think Sabah was talking about what is the minimum that is required, even though
Yeah.
that is going to be very difficult. Because if we are already talking about tele-rehabilitation, community-based rehabilitation, defining the minimum is really going to be tough because if family members are involved in performing simplistic interventions, routine intervention, that could also be the minimum. At least it's better than nothing. So defining the minimum is going to be difficult, and perhaps such the kind of questionnaire being requested is something that will require a lot of people contributing into the different elements of such a questionnaire in terms of what is required for physical rehabilitation, what is required for occupational therapy, what's required for speech and language that can be done in different facilities and perhaps even at home or in community-based facilities. I think the amount of intervention that can be done will vary from facility and setting to setting because certain things may not be safe to be performed in the community, whereas they may be safe to perform in sophisticated centers, tertiary institutions which have multidisciplinary facilities and gymnastics and robotics and all of that. So what is going to be required with different, will differ from place to place. Even for tele-rehabilitation, it depends on what kind of gadgets are available at home, and then who is at the other end of the tele-rehabilitation conversation. Is he a therapist or is it synchronous tele-rehabilitation? Is it asynchronous? Asynchronous whereby the packages are already pre-recorded and are just being dished out online without any interactive way of checking with any therapist that is remotely intervening. So it's very complicated and it's going to take a lot of interactions. Thank you so very much. So, but
Okay.
it's something worth thinking. Yeah.
Yeah. Are there more comments on this from the panel?
Volker, if I may,
Sure.
I would like to give a short comment on tele-neurorehabilitation related aspects. And I do believe that this is crucial in many respects. And tele-neurorehab is so important because, it keeps still the human component in its transition to artificial intelligence and virtual elements that will be added successfully. But what is most important is to have some models of action regarding implementation of tele-neurorehabilitation. And I just want to highlight again how important it is to have these models and again to handle the contribution of WFNR and WSO regarding tele-neuro rehab related aspects in Romania within the frame of the National Plan for Cardio and Cerebrovascular Disorders. So we have been able to change a lot and to change dramatically the landscape of stroke treatment and the stroke rehabilitation in this respect. And I think it's important to generate models and eventually to test them as pilot projects and to run them and to see what is good, what is bad, how can we improve that. It's a living example of how can we develop in a very precisely defined environment, especially in the environment dedicated to low and mid income countries.
Yeah, I totally agree. I think we are at the very beginning of using this systematically. And we also in future will certainly be faced with a lot of legal problems, for instance, also liability problems. Who is responsible for the content? There are some ethical problems involved, all of this. But nevertheless, we should go into this direction. We will learn from this, and we should not have too many prejudices in going over this limbus and entering this field. It has been invented 25 years ago. It's not a completely new concept.
Absolutely.
Today, the technical facilities are much better. There was a question, it's probably a little bit related to me from Kalari, on the metaverse, on the metaverse concept. The question: could you share your thoughts on how we could tailor the education to the individual needs and make it person and family centered? yes, the idea of this metaverse concept, by the way, is not tailor rehabilitation. It is tailor education. So this will not be a, let's say, system to do direct rehabilitation. It's a system to educate patients, to educate relatives, caregivers, also therapists, physicians, even on aspects of rehabilitation, which is a somewhat different issue. But nevertheless, it's so flexible that it can be adapted to all sorts of needs. And what we certainly, after we have reached the next step, which probably will be ready by autumn this year, if we reach the next step, that we can roll this out for a limited number of centers first, and second, to have more people coming in and fueling in also their ideas and inputs, which can be, that's transferred into this metaverse environment, if you like. It's this digital environment. It's probably more appropriate to say it like this.
Hai 2 minute. Visto che se ne è messo il telefonato.
Okay, this was probably not a question. Okay, Ambassador Permanian from Mauritius, he asked, what strategy do you advise with politicians? What a question. Is anyone willing to answer this?
I have a strategy.
Well, I
but
have handled.
I have a strategy, but it might not be airable.
I have been working with the politician for last 12 years.
Yeah.
And it is your sincerity and hard work which drive them. I've been the most respected. If I call any politician for any camp or any program, they come because it is their program which I am doing. And we do for our promotion, then probably they will not support you. But when you do the work selflessly and they realize that we are doing their work, they are always with you.
Yeah, there's an old strategy to make them believe that it was their idea, what you're doing. That's a different issue. But Matilda has raised her hand. Yeah.
Yes, I think that this question is crucial for all of us, also in light of the change of WHO that really wants all the community to work with politicians. And in terms of national work, I believe that there is a role that sometimes cannot be done at the single level. I mean, the person on its own, but certainly societies like the National Society of Rehabilitation or other societies working together with Patients Association can help to speak to politicians. The use of a combined lobbying with Patients Association is something that you should always consider when you want to bring politicians to do something with you and for you. And the suggestion is, in many countries, Patients Association are not strong. And that is a pity because they really would have a lot of advantage in learning how to create community. And this is the role of professionals, to help also patients at national level to create patients organization where you do not have patients organization. So how do you speak to politicians? First of all, every person is a vote. Politicians are usually voted, and having a great mass, usually, and having a great mass of people going towards the same goal is something that helps also to create attention of politicians. So my suggestion would be, following the new toolkit of the WHO, which is providing clear indication of what can be done from a bottom-up approach, trying to create a top-down approach, but always working with the multi-stakeholders. There are some objectives that are common, not only to neurologists or neurorehabilitation or physiatrists, but also to many allied professionals, psychologists, physiotherapists, occupational therapists, and all the others that are working with us, and to all the patients' organization, learning to work together, creating some tables that could create, for example, in the brain health strategy in the 5 countries in Europe that are having it, they are creating tables where common goals are defined using the WHO gap, and building up slowly is always something that politicians can hear.
Okay, Daphne had a comment on this.
Yes, indeed, and I strongly believe that Matilde is not only a master in doing this, but also having a deep knowledge and practice. But what I would like to mention is that, again, piloting in the real world and creating models of action and interacting with politicians. I believe that, as you may remember, that a special session in the National Forum of Neurology in Romania, and this National Forum is a model for us to interact with politicians and everything, because it's extremely successful.
That's in your mic. Is far. We cannot hear you well.
Do you hear me now? Do you hear
Now,
me?
yes.
Yeah,
Now,
better.
yes.
Yeah.
Yes. I just said that very much appreciate your fabulous experience, Matilde, and I think this is a great added value and help for the whole environment, and particularly in acting with these difficult elements, political elements, which is not easy. And just to mention that we have created a model also in this respect. It's a National Forum of Neurology in Romania, and WFNR, EFNR had a special session during this important meeting, and the core elements of this meeting is to put together at the same table doctors, patients, industry, and politicians working together, and particularly the payers, those for National Health Insurance House, and those creating health projects, health programs, all kind of political related developments, and discussing and speaking openly to each other, and having a common plan, a common, clear, defined plan with goals, and evaluating these goals along the way, goals and deadlines for politicians, which is absolutely great, and it gives us really a good perspective and good, I would say, good results.
Well, guidelines for politicians are certainly a very dreamful way of thinking.
Yes.
But I think this is a never-ending story, and all of us must be aware that we have to deal with politicians and decision makers in various and we have to find clever ways. The eminent German 19th century pathologist Rudolf Virchow, he was the inventor of cellular pathology, and he was a politician as well, and he came up with a statement that he said, politics is medicine in large, and that is probably true, and we should keep that in mind. In any case, we will not this afternoon solve this problem, but we have to keep it in mind, and it's always good to discuss this. So I think if you don't mind, we will go on. Our next speaker is Professor Wayne Feng. He's the head of the stroke and neuromodulation department at Duke University in Durham, North Carolina. He is the regional vice president of the World Federation for North America. And today he is speaking about a very, very important aspect on prevention of stroke and vascular dementia. Wayne, go ahead.
Okay, thanks, Foucault. Can you guys hear me okay?
Yes, I can hear you at least.
As we all speak about neurorehabilitation, help a patient getting better after stroke or neurological disease, I just want to highlight a few important things. Is we can't just do neurorehabilitation by ourselves. We have to work with our colleagues, to treat a stroke and prevent a stroke while we actually rehab those stroke patients. So here's really what I want to talk about: the preservation, preserve the brain, prevent a stroke, and use brain plasticity to help a patient better. Our goal is the same, and prevent a stroke, prevent a vascular dementia. This is my disclosures, and as you all know, dementia is a loss of brain functions that affects the daily activity and then functions. Vascular dementia is the second most dementia after Alzheimer's disease. It has three types: mixed dementia, and basically it's a co-condition with Alzheimer's disease, and a subcortical vascular dementia, and a multi-infarct vascular dementia. It is prevented conditions through stroke treatment, recovery, aggressive risk factor, and modification. We can almost say prevent a stroke, you really prevent a vascular dementia or prevent a dementia. So how we can achieve this? Well, there's two types of stroke. One is bleed, and you have your pipe burst and you have blood in the head. The other conditions, you have a stroke, you have a clot in the brain. And what we talk about today is mainly focused on ischemic stroke, because now we have ways to treat this disease, and we still come around how we can treat a patient with a hemorrhagic stroke. So how are we going to treat early and preserve the brain? Well, Jeff Sabe from UCL quickly said, we need to act fast, be fast, recognize stroke symptom, give the medication. Otherwise, every minute we lose about 2 million neurons, and every minute. So how are we going to treat it? We have two medications, alteplase and tenecteplase. If you treat them, and patient have 30% more likely to achieve function independence at 3 months after stroke. And those two medications are equally effective, and its side effect is pretty much similar in terms of risk of the brain bleed in the head. The medication do have to give it within the 4.5 hours. Again, we have to be fast. Okay. Beyond the 4.5 hours, you can do multimodal imaging, which is still not available in majority of countries, and for those that have the technologies, you can beyond a 4.5 hours, if you have a big clot and the brain tissue not a complete data yet, you can do it in a catheters and basically drag the clot off, and the patient can have really good outcomes. Again, this picture really can show you we need to act fast. And there are situations, and Dr. Coley said it, there's a golden hour between life and death. If you got injured with heart attack, respiratory stop, massive bleeding, but if you can get to the hospital within the 60 minutes, 1 hour, and most of the time we can save you, or we can change the outcome. But if you not make it to the hospital within hours, some of the damage into your body just cannot reverse. On the right side, I really can show you, if you treat a stroke patient 90 minutes after stroke, you treat two patients, one patient will be functional independence at 3 months after stroke. If you're a little bit slow, treat the patient at 2 hours after stroke. You have to treat 4 patients. If we further slow, you treat the patient at 3 hours after stroke. You have to treat 9 patients in order to have 1 patient to have a functional independence at 3 months. Really, to highlight, we have to treat it fast so we can achieve the function, have more patients achieve functional independence. So that's why American Stroke Association said, well, we need to have the best targeted metrics is you need to treat half a patient within 45 minutes. Treat half a patient within 30 minutes when they hit the emergency room. And the 75% of stroke, you treat them 45 minutes. So what I'm saying is it's so important to treat the medication, but why we still not there yet? In the US, we still only treat about 10% of patients with stroke. Why is that? Because we need to build more stroke centers, okay? There's still not enough stroke centers. How we can help a patient to get into emergency room within 4.5 hours so we can give them lyrics? United States, three quarters of the country are in the rural area. There's simply just not enough neurologists there. Can we use a telestroke approach? Or we can drive a stroke mobile units with a CT scan. We can just give a TPA on the thing called stroke mobile units. Okay. All this, we need to really improve the utility of those life-saving and disability reduction in treatment. But we're not there. But through those 4 approaches, we hope to get there. Here, I just want to show a picture. This is the state of South Carolina. It's about the size of Austria and Portugal in Europe. On the left side, it really show you only half of the states are covered by telestroke. Means after stroke, you drive 1 hour, you can be seen by telestroke specialists, or you can treat the thrombolytics. But with telestroke, 98% of population are covered by telestroke network. Means you drive 1 hour to the ED, they are telestroke specialists who can give the medication. With this, we can really rapid and provide a coverage to treat more patients. Stroke mobile units, majority of those ambulances are driving in Europe, and there are several in the US just due to the population not very dense. There are 13 stroke mobile units in the US. Majority of those are in the big cities. In China, there are a few of those as well. There's a study was done at UT Houston really can show you using stroke mobile units, we can treat it faster, and there's more patient can end up with a better outcome, So with this, I really want to say, first step is really to treat them fast, preserve the brain. What's the second step? Second step is really recurrent stroke, prevent further brain loss, so we are better positioned to achieve and brain health. So how are we gonna do that? We have to implement ideology-based second stroke prevention regimen. I was trained with Dr. Kaplan, and he was trained by NSC Miller Fishers. They always say make an accurate diagnosis, determine what causes stroke, okay, and then you prescribe specific prevention regimen. They even say if a patient comes with a stroke, it's your fault as a doctor because you need to figure out what causes stroke. And so you can put a specific regimen so you can prevent the next stroke and you can prevent a further brain loss. We use a TOASTER criteria, pretty much use widely across the globe. Large vessel occlusion means you have built atherosclerosis in the large vessels, both extracranial, intracranial. There's specific treatment for that. Small vessel disease basically affect a small vessel. You really need an aggressive and modified risk factor. Cardiac mechanism. You have a stroke, but you troubles with your heart. Most of them have atrial fibrillation, or there's embolus form in the heart. They swell from the heart, causes stroke. Okay. And there's unusual cause, dissection, and hypercoagulable, such in the setting of cancers, arthritis, autoimmune disease. Those are not. And there are certain conditions we just don't know, and we need to continue to figure out the etiology. If even patient discharged from the hospital, we need to see them in the outpatient clinic, figure out what causes. Because only after we know what caused stroke, so we can figure a way to effectively prevent the next stroke. Okay. There's a lot of embolic stroke with undetermined source. We are not sure where they come from, but with a lot of those detection devices, we found there's more of those are actually due to heart issues. And with the new anticoagulant, and we have a better drug than the warfarin, now we're able to treat more stroke and prevent more cardiac embolic stroke. So how are we going to control risk factors due to time? I cannot spend more time. I think those things are very simple, called a Life of Simple 7, proposed by American Stroke Association. Stop smoking. Think about how many people still smoke those days worldwide. Eat better. We have access, better food, but are we really taking advantage of eating better? We need to lose more weight, okay? We're getting bigger and bigger. We need to control our cholesterol. We need to get active with more carb available, but we are getting less active. We need to do more exercise. While we're eating more calorie, eating more carbohydrates, our sugar levels getting high, more likely to get diabetes when you reduce sugar levels. Blood pressure, change our lifestyle. We sleep less, and our sympathetic tones increase, and compared to decades ago, blood pressure continue goes up. We need to manage our blood pressure. So those things are easy to say, but it's not easy to do. But I'm not going to spend much more time. We all need to work on this. Okay. So I just talked about second step is really, modify stroke risk factor, find the etiology of stroke, prevent the next stroke, prevent the brain loss. Our third step is really use brain plasticity and to recover the brain and recover the body function, okay? And so stroke still is a leading cause of disability in the US worldwide. And motor impairment, the most common complication of stroke. But besides motor impairment, there's so many other complications. There's spasticity coincides with motor impairment. there's pain associated with it. There's sexual dysfunction, sleep issues, seizures, which we have two speakers just spoke about it. We have aphasia, language communication issues. We have cognition decline, which we are trying to prevent today, is prevent stroke, prevent dementia. There's neuropsychiatric disorders after stroke, you name it. It's not easy to deal with all the complication after stroke, but we need to work on to prevent those complications and minimize the complication, also and treat those complications so they can have a better function. There are better guidelines right now, but we still need to work a little bit better. In the US, we have a 2 version of a guideline. There are 30 versions on. Canadian just put a good PECS guideline for rehabilitations. But a lot of country and in the developing country, simply we don't have a guideline, or we simply just copy and paste and a guideline from a developing country. This probably also need to be changed because the situation is very different. Guideline from one place may not be necessarily good for the other country, but this moment we're probably just going to utilize the best evidence we have and to, and for recovery best we can. First important thing is really all talk about is motor recovery. We need to really to know, understand the recovery process, find a way, target how we can modify this process to reduce the disability and after stroke. For example, we need to have better understanding about a cortical spinal tract, which is anatomical location, and to control them and the motor function. We can do clinical assessment, neurophysiology, MRI scan, but we also make sure which of those are feasible to do in the developing country versus how many of those can do the developed countries where it has a little more resource. Kazakhstan from New Zealand proposed called PLAP. Looks great, but you have to do TMS, MI. How is that feasible? Was this will be deploy this algorithm to, and to half of the country in the world? They simply just cannot. Simply they just cannot do TMS. They can't do MI scan. So with this, they come up with called PrEP 2. Forget it, MI scan. Maybe we can still do MEP, use other age, clinical assessment. Maybe we can achieve the near as good as PrEP 1, so we can have a better triage of those patients. Or we can use a method come from my lab, just use a clinical MI scan. We can calculate the lesion load, and then we actually, in the first 7 days, we have to do additional MI scan so we can know some of those patients who are, lesion load less than 7 cc, they maybe still have a better chance after 7 cc. A lot of patients simply just cannot have a reserve to have a better motor function and after stroke. If a patient, and not too bad, they still have a distal movement, simply we need to give them more therapy. Doses matters. Intensive therapy is constraint-induced movement therapy. It will cost a lot of time for the physical therapy, but they are effective. We have a good evidence. We just need to promote this, or we can figure out a way to, train a more physical therapist, or we can use some physical substitute, to incorporate some of those concepts of CIMT, so we can provide intensive therapy to stroke survivors. We do need a high technology, such as vagus nerve stimulation, the first invasive device approved by FDA, and really can use for ischemic stroke patient with moderate motor impairment, and with the device and along with the physical therapy, 6 weeks in treatment, and 1 out of 4 patients will have a significant improvement and with their motor function and also reduction in the disability. But big issue is cost is a major barrier. When you think about implementation of science, how many of those patients really can benefit from this? Simply just says this, even in the US, after device approved in 3 years or now 4 years, almost 4 years, we still only have a 200 patient and receive this device in the US. Not to mention what's a possibility to get those devices worldwide, just to give a concept, 200 patient, and was we have 750 new stroke every year in the US. So yeah, those high technology is great, but the cost is the major issue, So how we can really promote those non-invasive devices such as transcranial direct current stimulations, simply a few $100 or even less. You can make a device and you can do the therapy and with a PT and OT, or you can do online trainings. This is a study I led in the US first because we have to establish evidence. The study we basically just completed and the enrollment. Hopefully we'll present International Stroke Conference, or maybe we also present at next Congress or the European Federal Congress on Neurorehabilitation. And so those kind of things that they are more likely to promote because they are much affordable and in terms of cost. Maybe we can do devices transfer C7, through a surgery, so we can have one brain, just one side of the brain control both sides arm. The surgery itself is pretty extensive, but we maybe can train more surgeons and they can do the surgery. Of course, cost may be issue, but but some of the place the cost of a surgery is not as high, as you think. So those are all the new tools, are in the development. Use epidural stimulation both at cervical or at the motor cortex level. Deeper brain stimulation through the cerebellums, maybe new ways, or use low frequency, low intensity electromagnetic stimulation, maybe, or through our endovascular, we can stimulate the brain less invasively. Maybe that's the future, but we really need to balance the cost and the feasibility. Think about implementation science first when we develop those technology. Otherwise, you develop technology, nobody can benefit from this. Again, I want to have frame the concept. When the stroke is small, we need to simply just give them more dose of therapy. Most of the patients will live near normal, live as normal. Okay. For patient moderate stroke, they still have neural substrate. When you think about brain stimulation with intensive therapy, our goal is to help them live near normal. Okay. With bad stroke, we have to say sometimes you have bad stroke, maybe the cell-based therapy, exoskeleton, brain-computer interface, we can help a patient to find a different way to live. Okay, that's a framework. Okay, so again, I want to emphasize my talk. We need to quickly get them treated. We can preserve the brain. We implement a very effective and a second stroke prevention. We can prevent another stroke and prevent a further brain loss. Use brain plasticity, we can help them better. So they can have the best brain health as best as they can and to reduce and prevent them to progress to vascular dementia. That's the goal. And with this, I'm going to pause here for any questions.
Okay, Wayne, thank you very much for this quick run through aspects of stroke preservation, prevention, and plasticity, of course. And it's a never-ending task, of course. There's always a tension field between what politicians can do in changing rules. There's a discussion now in Europe on how to get rid of sugar-containing drinks, which may give rise to obesity and diabetes in an early stage and things like that. Probably a lot can be done by the way, urging people to go into a particular type of lifestyle. And well, it's a political and a philosophical question. If states, governments, politicians in general should do that or not. And that violates, of course, many, let's say, liberal thinkings. And I do not want to look at the situation in the United States at the moment, but many comments on this. But this, this tension field is certainly existing. And we, as physicians, therapists, and people, clinicians in general, we cannot escape from that necessarily. Okay, let me look at the chat room. There's nothing new in that, and the question and answers. There's also nothing new in that. No. Okay, so Wayne, thank you very much, and I think we carry on to our last speaker, is Professor Dafin Morijano. Doesn't need any introduction. He is head of the neuroscience department at the University of Cluj-Napoca in Romania, one of the founders and the current president of the European Federation of Neurorehabilitation, engaged in the field of education in neurorehabilitation and general neurology for more than 20 years, and I had the pleasure to work with him in many of these endeavors. And today he is going to share with us his thoughts and concepts on, let's say, brain reserve and brain health in general, and how that matches with neuroscientific knowledge. Dafin, go ahead. Thank you.
And I will just try briefly to fly upon the concept and to let you know at the end about the practical things that we have done in order to have a progress in measuring this very volatile element. This is a very volatile because it has so many facets that we cannot even grasp the whole concept in a, I would say, in an easy way. Let's try to go on and do that, of course, very special regards from my university, for our Institute of Research, RONeuro, who is also a supporter of this meeting, not only intellectually but also financially. And I think we have briefly to acknowledge the roadmap of this talk, which is to conceptualize a little bit the brain reserve and then to see how can we eventually quantify. Of course, we need to operationalize this and then to ask the very legitimate question, can be this enhanced or recover to some extent? And the answer is definitely yes, to some extent, and depends on many factors, and particularly depends on our behavior and our emotional status. Then I don't think that we'll have too much time to go into the integration of this complex concept into research, but I will just touch upon, and we have to look at the new horizons and new development of the concept. Now, as a concept, we have to be very clear that the concept developed based on the very nice background, the background that solved many dilemmas in the last 20 years. For example, we are placing, neurorehabilitation, brain recovery on solid basis, on basic research. So this is the first pillar, having everything as a reference on that direction. Then with the help of basic research, we have understood the post-lesional brain regulation, which is very complicated to be understood also today. Understanding post-lesional brain regulation, this would be the key element of future development. Of course, for practice, we need to be as much as possible related to evidence-based medicine, and at the end of the day, when we are using an intervention, whatever intervention we'll use, especially, for example, even a word can be an intervention. The way in which we address a patient, the way in which we approach something, this is an intervention already, but any intervention will be influenced by external factors and our endogenous factors. And that is the key, because if you have an intervention addressing a medicine, a drug, any kind of that, this will not act in the vacuum, will act in the concrete context based on how much biological reserve we have. And this is another progress in understanding the complexity of brain recovery. Now, to put it directly, historically, we had two kind of approaches, the structural brain reserve and the functional brain reserve, that we usually call it also our cognitive reserve. And that it's important because at the end of the day, there is only one biological reserve, but these two are still able to be distinguished in a certain way. If we look back historically, the first important document paper was published in early 90s by Paul Zatz, giving us the chance to, I would say, intuitively understand biological reserve and to see how we'll approach this from the structural perspective, put it in a blunt way. If you have more brain, you may have the luxury situation to lose some brain. Yeah, you may lose something, but if you are not so well equipped, then it will be a problem. So he developed so-called structural and temporal model of brain reserve. I will not insist on that, I presented before, but it's very simple. If you have a lot of brain, if you have enough and you have a good capacity and a good health, if something will happen to you, will not be clinically relevant at the moment. We know from our experience, and our strokeologist knows very well, that we have so many silent infarcts, yes, and cerebral infarct. And this is also an expression of how different parts of the brain may compensate a certain deficit. So going further and highlighting the idea of the hardware and the software of the brain, when we are talking about the hardware of the brain, we look into the structural capacity of the brain, and when we are talking about the software of the brain, we look usually, and especially now in the last decade, into the connectivity capacity of a certain brain. Then, of course, we have to look into our heritage, our genes, and how these genes will be, I would say, favorable, facilitated or not. This is up to our lifestyle and our behavior. Of course, this mechanistic, I would say, concept had some success, but currently we are contemplating in a very, I would say, contextual way. We had many gaps, I will not mention in all these elements, that haven't been considered in the past. Not only the way in which we are measuring, because now we have many biomarkers, we have developed the idea of biomarkers, we have understood the genetic and environmental factors, we have developed the science of epigenetics, which is unbelievable, and we see how environment and human behavior will change this situation. Then we have a huge variability based on cultural approach, populational approach, and of course economical status. And we are going to have less and less blurred concepts, less and less, and to conceptualize better biological reserve. And if we'll be to redefine this, I believe that it's important to mention that it's not only about the hardware and the software of the brain in the sense of the neurovascular units, circuitries, and large-scale networks, and the way in which we are creating connectivity, but it's also about the environment. And this is related to the lifelong dynamic interactive accumulating capacity to resist to physical, emotional, and social harms. So that would be, I would say, a reasonable definition. And this was published by our good friend, Professor Vladimir Hachinsky, some years ago, and we may consider as a very recent definition. We add in the last years to that an important fact that brain reserve, I said, it's not only a volatile concept, but it's also a volatile element, but still most robust one that will determine our recovery capacity. So we know that we have enhancement, a chance for enhancing brain reserve. We have factors that will act in a positive way on biological reserve, like good mood, the chances to socialize, as Nathan mentioned, to dance, to be happy, to stay with the friends, to experience positive things in life. This will really develop, and to learn particularly, to stay cognitively active. That will help a lot. Then we have negative elements, negative physical and psychological emotions, and of course stress will decrease the capacity of the brain to recover. And that is really an important part to see how variable is. Why? Because if we look into the relation between the cognitive, so-called cognitive and brain reserve, actually the structural and the dynamic network of the brain, we'll see that there is an absolutely mutual influence. Whatever functional trouble we'll have will reflect into the structure, and if we have structural problems, we'll have an impact on the functionality of the brain. And the interplay between the software and hardware is huge, and we can talk a lot about this way and the patterns of disruptions. And I think in the future we need to define the patterns of disruption of brain reserve and the pattern of disruption of brain health. And I think this is a very important endeavor. But to operationalize is not easy, but we have to define indicators and variables that can be measured in order to quantify to some extent. I'll tell you, and I think we all agree that it's impossible to completely measure this. Because if you have a person with an excellent, I would say, collection of biomarkers and apparently healthy, if the person will get a certain, I would say, unexpected situation, and if the person will not be happy, if he will be depressed, his resistance will melt down immediately. And if you have a creepy guy in a very difficult condition, he will say this way, this is going to be the end soon. And if you will face something very good, very positive, then you will see a kind of rejuvenation. So this is very volatile, and we cannot understand, we are not able to understand all the substrates of this unbelievable, I would say, complex idea and I would say biological reality, let's call it. So if we'll be to define this important post-lesional brain regulation element, that is really important, because we are medical doctors and we are treating patients at the end, and we have to understand the brain lesion. And then we have to look into the brain capacity, how brain does after a lesion, how brain does after a stress. And today we know and we have understood, and maybe this is the most important achievement, is that after an immediate lesion, after an acute lesion, there is a robust reaction of the brain having two phases. The first phase is very short and I would say mild, which is the endogenous protection, and will not last more than 72 hours maybe. And then it's coming the second phase, the phase of recovery, which is lasting for weeks and sometimes months, depending on the brain reserve, of course. The key is that these two anti-correlated processes occur continuously, and in fact they are anti-correlated. When protection is up, recovery is down. When protection goes down, recovery goes up, because it's in the logic of the biology. For example, the glutamate is bad in the acute phase, but without glutamate we cannot recover anything on the long-term run. So the brain knows how to balance this by endogenous programs. And I think this is a very important element, the anti-correlation in brain function, anti-correlation between apparently antagonic principles but which are extremely entangled. It's impossible to disentangle these processes, and whenever these processes will be disentangled, then we have a terrible disturbance and a disorder of the brain. We have the example in the acute phase, the volatile, immediate brain reaction, brain reserve after an ischemic stroke, after an ischemia, because ischemia is moving the brain through different types of phenotypes, is moving the neurovascular unit by homeostatic, preconditioning, and the delay cell death phenotype. And of course, I'm not talking about the necrotic part because that is the end. But the idea is that the capacity to defend, it's limited. You see the green curve here. Yeah, so the capacity of destruction is tremendously high and will go up, but the capacity to balance and to recover it's limited. It will be consumed. In the first phase we have the stress response. Yes, the stress response, which is actually the manifestation of biological reserve, is very robust, then it's less robust, then it's almost equal with the capacity of the brain to, let's say, to stay somehow on the edge, and then it's consumed. So we have to look and to distinguish between immediate brain reserve and long-term brain reserve. The immediate brain reserve is the capacity to protect, and the long-term is the capacity to recover. And this is important, and this acts at all levels: cellular, molecular level, circuitry levels, and the dynamic network level. We know that the brain is organized based on this model, small worldness organization, and we know about the connectivity, we know about the connectome. The connectome is the substrate of cognition. We know the cognitive domains as described are DSM-5. Now we have this complex domain. And you know, we cannot disentangle them also, because the cognition is linked to the motor, because if you need to move, then you have to think, you have to feel, you have to have a motivation. So in fact, it's just an artificial separation, and for the medical part, but in fact everything is interconnected. It's very difficult to separate these elements. And we strongly believe that this is the privilege of this integration, is the privilege of this connectivity, this fabulous reserve of the connectivity. Of course, and this will occur in the external brain and the internal brain, and these two parts of the brain, of our brain, are very much connected by this salience network, which gives us the chance to focus to the relevant stimulus, and then to have the reflection in the absence of external stimulation, activated the default mode network, which is a very important part of our brain, or focusing on the external elements. So the default mode network, in a very schematic way, it's here, and then the executive part is there, and the salience network will set the tone for an in and out. Inner activity and activity dedicated to external elements. So the capacity to anti-correlate our internal brain and external brain, it's the ultimate definition of brain health, because the primum movens in, for example, in Alzheimer's disease or any cognitive impairment, it's the absence of anti-correlation between default mode network and the executive networks. When the default mode network cannot be deactivated during an external task, then it's a lack of anti-correlation. And this is the beginning of dementia. It's the beginning of cognitive impairment. It is the new way to understand how everything functions in our brain and how volatile it's everything. Of course, these networks are correlated with the genes, and whenever we have an active function somewhere in the brain, the genes will be activated to provide whatever is necessary, from blood supply to whatever element necessary for activity. And we have this correlation matrix that can define the matching between gene activation and network activation. Now, to define, this is the end of my first part of the presentation, talking about how the context in which we are conceptualizing brain reserve. And to make the long story short, if we have any kind of disorder, we may introduce it in this model, any kind of brain disorder. We have two models, yeah, of troubles created by imbalances in anticorrelation. We have a bottom-up model. The bottom-up model is very intuitively, because if you have a biological agent, a chemical, physical, or whatever, then the hardware of the brain will be affected, and cellular molecular level and circuitry level will suffer. So we'll have a kind of bottom-up, and at the end of the day, the networks will be disturbed, and this will be reflected into human behavior. But it might be the case that we don't have such a situation. We just have the simple unnecessary super stress, negative neuropsychological agents acting from the top to the networks, to the circuitries, to the cells, and creating disorders. These are two important models, bottom-up and top-down, because negative emotions can create definitely human pathology, and we know this. And the stress is bad, and we have the example of the great study of Tabasco performed by Nathan and the Israeli group, which demonstrated that we should look at the stress not as a consequence of the risk factors, but as a primary element for creating pathology. And this was the huge added value of this research. And I think we have to go on quickly and to say that today we are privileged, because we have these biomarkers that can measure the brain reserve. There are many biomarkers, I will not insist on them, but the biomarkers will help us to define what is the patient potential for recovery and what is the best rehabilitation strategy for a certain patient. And of course, we have to look at all the domains, motor, cognitive, language. They are separated because we have to separate them somehow. But at the end of the day, they are combined. And we have two types of biomarkers, the biomarkers that will measure the hardware elements, the structural biomarkers, and we have the functional biomarkers. But again, there is a combination that we have to classify them somehow in this respect. Then, if we talk about stroke, for example, we have these motor biomarkers that are complex biomarkers measured by clinical elements, neurophysiological biomarkers, we have neuroimaging, we have complex assessment of blood supply and many other elements. But on the other side, we have the cognitive biomarkers, language biomarkers. And if we combine all of them, then we have a kind of gestalt, a kind of general perception of the biological reserve. It's difficult because we still have to work, because we are not able still to standardize and to reproduce perfectly and to interpret this, and we can improve this landscape of biomarkers and the usage of biomarkers by defining this very important concept of individual resilience index, IRI. And this will create more power to the biomarkers. And how is this possible? It's possible by measuring in different ways, different elements. Yes, we can measure in a healthy person the complexity of biomarkers and put them in a certain mathematical matrix. Basically we are normally we are working here in the impaired, we are working with patients, but you have to do it also on the healthy population, to repeat measures and to have an idea about how a healthy person evolve, how a healthy person develop. But usually we have patients, and we have to look into the acute, early subacute, late subacute, chronic elements, and to distinguish and to measure all the time dynamically this. The key is to measure dynamically in all phases. This is the time points of this. Then we have to give weight to different parameters. For example, in our model, and now I'm switching to a practical thing, how we'll measure what we'll measure. So, and we'll have a complex index, and then in our model we are using this segmentation, 20% structural reserve, and 20 for functional metabolic, 20 for cognition and psychology, 10 for genetics and epigenetics, 10 for lifestyle, clinical history 10, social economic 10, and of course we have to take in consideration the temporal dynamics, because look, in the case of stroke, for example, this is very important. We have a complex methodology with multidimensional approach. I will not insist on that, and we have to have we need a meta-analytic complex approach and a working draft of indicators. What we are using, parameters now, coming more and more concrete. Structure, for the structure, we need this from total brain volume to subcortical structures and volumes and whatever. And we measure connectivity, we have functional and metabolic, we have these parameters. And then we look into the cognitive and psychological elements, all the scales and scores, exploring, I would say, the emotional universe, the cognitive universe of the person. We have these genetic and epigenetic factors combining the different types of polymorphism and indicators for methylation, demethylation, and whatever dynamics of the processes are described. Lifestyle factors, very important, from physical activity to diet and smoking, which should be considered, and then clinical medical history with, all kinds of comorbidities that have to be considered. Social demographic, with an important impact. We know that this is delicate, and again, temporal dynamics. Temporal dynamics, very, very proeminent, especially in stroke. We need to measure timely. This is the model of development for the collection, and I will give you now an example how we did complex measurement of individual resilience index, and we had the first important approach based on the results of ESCAS trial. If we look into this, we'll see how much variability we have. For example, apparently two identical patients will have a totally different evolution and capacity of recovery. We are in a situation of having two patients, for example, both in intervention group, both of them. We did this after the unblinding. We did these measurements, the matching and everything. Two persons with similar economic context, with similar comorbidities, with identical stroke location, with mixed transcortical aphasia. So almost similar. Even, we have a difference in the age. One is older, one is younger. But look at 90 days, a huge difference. What a surprise. The older guys had a better recovery and better context, absolutely good evolution. The younger one, unfortunately not. Why? And we have here the whole background and the theory of biological reserve. That is the reality. Different levels of brain reserve. This will define definitely the sense and the possibility of recovery. And we measure the IRI, and definitely we had the good surprise to see that what we have clinically evaluated and let's say witnessed, it's matching our calculation. In this type we have IRI 0.46 for the patient, the first patient who had a less dynamic recovery, and we have here 0.72. This is a one type of measurement, because we may measure IRI, you will see On the large scale, this is an individual based, but if we'll measure, let's say, based on a population, then it's different. The higher the index, the less capacity of recovery. It's a mathematical, let's say, approach which is not easy. Okay, what I would like to show you now at the end of my talk is that we have to be better and better in evaluating this IRI, and we need a large-scale prospective study, and we did it in combination with many databases and working a little bit hand in hand with American colleagues that gave us the chance for a good collaboration, and we use clinical data, imaging data, demographic data on a large population. Look here, we have this database, very important database of National Stroke Center in United States. They gave access for us to more than 2,800 patients, having all MRIs, all imaging, clinical elements, having access to all, I would say, the whole complex database of evaluation. And we match this, stroke-related database with all demographic information, whatever you may imagine, including this modifier ranking scale and whatever. We match this with another database, which is the behavioral risk factor surveillance database, also from United States, which is not about an acute disease, but it's about the risk factors. And we match the risk factors with the acute, we put together and we calculated all this, and this was very successful. And we had the surprise to combine these two databases, and we had around 40 variables measured and matched together. And we have been able to describe and to calculate the resilience index in a very new way. It's the unique way. Nobody did it in this way so far, but this is a model, and we have to contemplate if we'll go like that in the future. We standardize variable by Z-scores. We combine into a single resilience score. We match by absolute model and relative model. These are just technical things. Coarse exact and exact categorials for all these elements, all these data. And then, look, everything matches. Everything matches. This is the distribution of stroke IRI. And if we look here, we see how easy it is to lose the brain reserve, how difficult it is to get it back. And the higher is the score, the less is the brain reserve. And this matches absolutely up to 99% with modified ranking scale. And this was a very interesting surprise. At the end of the day, we had 2,553 cases matched. And we can talk more about these results, but for the moment I just wanted to present this very solid result, because the B coefficient is 0.25, and of course standard error P and everything is to the top. So it's very relevant. So the message is, at the end, the conclusion is that individual resilience index eventually will have the capacity to describe better and better the biological reserve in the future. We have to be knowledgeable, we have to be flexible, we have to look into everything, we have to learn, and we have to, I would say, to do it better and better every day. And I believe this is the backbone of our success for the future. Thank you very much. I will just...
Okay, thank you very much, Duffin. This was a very extensive tour through the concept of brain reserve and how eventually reserve capacity can be measured. I think we are very much at the beginning, but looking at greater and greater, bigger and bigger databases may certainly be of help. Let me look at the question and answers. There's one question related to the availability of the webinar. We will try to put all of this on our YouTube channel or via the internet. Give us a couple of days to prepare this, but it's certainly available for a more extended time. Second point is, someone, Andrew Carr, is making a comment, and he said we need to harness biomarkers, but they often out of reach for low resource rehab centers. That is certainly true. That is certainly true. You've seen from the PrEP, for instance, they're simple clinical biomarkers which may eventually be helpful. The more sophisticated one, when it comes to neurophysiology, neuroimaging, and especially also to genetics, it will be much more complicated. On the other side, we have seen that the availability of genetic analysis is getting cheaper and cheaper, almost month by month. So that is also a possible chance. However, I think we have to think a little bit about what in ethical things we do with prognostic information. I think that is still a problem. If you have a bad prognosis, what are you doing with a person with a bad prognosis? Nothing, or you try to revert this. So we have to make our mind up. Prognostication is probably not the sole solution. But Sabat has raised his hand. Go ahead.
So I'm coming from the neurophilosophy and ethics aspect on this. So will we be, if we get better at predicting on individual resilience index and biomarkers for recovery, will we be going down the path of cardiology, where people with poor lifestyle and things are placed like at the sort of low priority list for heart transplant or such like that? Are we going to reduce the resources that we going to sort of treating the patients with poor resilience, so as to say we're going to withdraw the resources from that and to redirect it to better outcome patients? How are we going to handle this once we are better able to predict who is going to do well and who's going to have
Te-am sunat că mama mai tușește. Oare să nu vadă, să o asculte cineva la plămâni?
That moment.
Okay, well, that I think, Sabat, is a very crucial issue. It's tackling, of course, the utility aspect of medical ethics in general, and of course, one day or sooner or later, we have to make a decision. Right? We are living, and we will stay living, in a world with limited resources. And in a world with limited resources, there is always need for some economization of resources. And this economization has to be based on something. On the other hand, of course, every one of us will agree that every human being has the same right for some sort of interventions. This is the old utilitarian strategy of medical ethics. And of course, these two ideas clash. They are not easily to be put on one another and make them congruent. It's probably not possible to make them congruent. Sabat, what do you want to do? Eventually, you have an idea how this
Well, at the moment, if you look, I think the higher end patients who require more in sort of neurorehabilitation actually eat up a lot of resource and with not such good outcomes. People stay longer in neuro rehab units with more advanced neurological insults who have poorer outcomes. They have more longer term inputs in the community, and inherently they are sort of, if I may use the word, draining on resources more than the ones who would do well.
Yeah.
Now, cardiology and the liver disease sort of liver groups have come up with a set of criteria. You stop your alcohol, you stop this, and then we will treat you. Now, we are not able to do that in neurological practice. So how do we redirect the resource from where it is kind of on the basis of utility? I know you've talked about utility and justice, but there is another element of ethics, which is futility. On the basis of futility, how can we redirect those resources to those who are going to benefit most?
Right. Well, that is certainly worthwhile to think about that very diligently, and eventually also to come up with some sort of regulations. It will certainly be difficult to do that on a universal worldwide level, because the ethical standards, the ethical ideas, the moral ideas, and all of this are very, very different, are very, very different indeed. nevertheless, we have to face this problem and we have to think about this problem. I do not, personally, I do not expect that we have a universal solution for that. But
I think we need to develop the concept of palliative neurorehabilitation very rapidly.
Yeah.
And have the patients directed to that service as soon as we think that there is going to be a poor outcome. So we're not trying to sort of throwing them away from the treatment, but neuropalliative is, I think that's a very important concept that we need to progress.
That is certainly true, and we've never really elaborated that in detail. But I think we probably have to go into this direction. And there's another ethical aspect, of course, that is personal responsibility, and also this has to be addressed in some way, certainly. Nevertheless, it remains the prognostication issue is a very tricky one, right? First of all, you never know how precise or accurate the prognostication works. And eventually we would come to a situation that we have to make very, very bad decisions on this. And I think we have to be careful with that. Nevertheless, work on better biomarkers, better prognostication is not bad, but we have to do it carefully, and we have to keep in mind what aim and goal we're using it. That's for sure. Daphne, do you want to comment on this from your perspective on brain reserve?
Yeah, I thank you very much, Volker. I think you are totally right. What I do believe is that it's always better to do something instead of doing nothing. So basically, it's so important to take in consideration the concept of brain reserve and to use the available biomarkers in a very wise way, as you have mentioned, using wisely this and trying to create, I would say, good, clear patterns, and to check the concept in the real world practice as we did, I believe it's very important. And we have to validate step by step. The more we know, the more we add to the concept, and we may eventually revalidate. And I believe that in a couple of years, we'll be able to increase the accuracy of our capacity to a certain prognostic in a certain direction. So I think we are on the good way so far, but still we have to work definitely cautiously on this direction.
Well, it's always a good closing sentence to say that we are on a good way. I think I appreciate that very, very much. We had a long, more than 3-hour webinar today. May I, at the end, thank all the speakers and the audience discussing and our technicians in helping us again with that. We will try within the next week or so to make that available either on the website or on another channel so that everyone can have a look at this again. This was our contribution to celebrate World Brain Day. You've seen we are living in a complicated world, and the future of brain health is multifold, very interesting, an awful lot of options. Nevertheless, I think we have also experienced the situation that we have to be careful with many of these concepts, and we have to rethink them on and on to find proper solutions. So at the end of the day, thank you very, very much indeed. And I wish you a nice rest of the day, night, or wherever you are. Thank you very much.
Thank you.
Bye. Bye.
Bye. Bye. Bye. All the best.
Bye, everybody. Bye.